Assalamu alaikum everyone, my name is Armosh. I'm a fourth year medical student, and today I'll be joined with Shahad Murshid. Together we're going to be doing the OSPE review for CVP. Just a few things to keep in mind before we dive in. The stars in every slide that it's included in, it includes pictures or information that are important or we found in past questions. So keep them in mind and make sure you memorize them, these concepts and these pictures. Next up, check the notes section for information or explanation on anything that we're discussing throughout the PAL. Okay. Next up, it doesn't include ECGs. We didn't include any of the ECGs because there's already an ECG PAL that you guys can refer back to if needed. However, just to make sure that we're focusing on the most important stuff for OSPE, we include ECGs. And lastly, pictures are important for MCQs as well. So just keep that in mind when you're studying all of these things. Now, the contents of this PAL will include the cardiovascular system, the pulmonary system, and miscellaneous. This, of course, we will be touching on pathology, the clinical aspect, microbiology, and radiology if needed, okay? And of course, lab content. Starting off with cardio, vascular and ischemic heart diseases, okay? Basics of the blood vessels. Now, as we know, we start off with large vessels. They form medium vessels, and these medium vessels then form small vessels, and these small vessels coalesce all together into a system called as the capillary system, okay? Or known as the capillary system. Now, all of these are just important for the discussion that we're going to have today. So keep them in mind when as you're going through the PAL. Now, this is just a small table for reference. It's not that important, just so it creates a clear picture in everyone's head. Okay. Now, the blood vessels structurally are also different. Okay. So histologically, the high pressure vessels or the arteries, as we all know, are thicker. They have a thicker adventitia, a thicker tunica media, and a thicker intima layer. Okay. They also have something that the veins or the low pressure vessels don't have, which is the internal elastic lamina. Okay. This is not that important. Just keep it in mind, because when you understand the basics, the rest of the things are easy to understand as well. Okay. Now, as I said, the low pressure vessels are going to be just a little bit thinner in terms of structures, in terms of layers, I mean, and as we know, they're low pressure vessels. Okay. All of this is just to paint a clear picture in the head. Okay. Lastly, basics of the heart. Okay. So as we all know, the heart has many layers, and just to go over them real quick, we have the endocardium, the innermost layer, is the layer that is facing the blood whenever it's pumping, whenever the heart is pumping. And then we have the myocardium, the thickest one, and from its name, it's the muscle of the heart. And then the third layer that we have is the epicardium, and this is the last layer before the covering of the heart comes in, or the pericardium. Okay. Now, between the covering of the heart and the epicardium, we have the pericardial cavity, which is filled with fluid, and this fluid helps with the friction and protecting the heart and so on and so forth. Okay. Now, this pericardium is further divided into two layers: the parietal layer and the fibrous layer. Now, the most important one of them that is important for today's discussion is the fibrous pericardium. Okay, just keep it in mind because it's important clinically in a lot of the scenarios we're going to discuss. Now, before we jump in, just know that a lot of the pictures will not have a clinical scenario per se. There's going to be straight recall, just like this one. Okay, so we have two pictures over here. Can anyone guess what these two are? Perfect. So we have a hyperplastic arteriosclerosis and the hyaline arteriosclerosis. Now, both of these, from its name, they're subtypes of arteriosclerosis. Starting off with hyperplastic, we're going to start with the two identifying features that led you to this to the answer that this is hyperplastic arteriosclerosis. We have the onion skinning, okay, onion skin appearance, and we have the obliteration of the lumen, okay. So the lumen, as you can see, is almost non-existent. You can't even, there's no, it's obliterated. And the onion skin appearance can be seen over here because of the fact that the layers almost look like the skin of the onion. It's they're over each other haphazardly. So this is why these are two identifying features for hyperplastic arteriosclerosis. But moving on to the hyaline arteriosclerosis, again, from its name, there are hyaline depositions in the blood vessel wall, and it just narrows down the lumen of the arteriole. Okay, that's it for it. Okay, and the main thing that leads to hyaline arteriosclerosis is the fact that it's secondary to two conditions: hypertension and diabetes. Okay, so if there's hypertension and diabetes mentioned in the question, you know. Okay. Now, these two pictures, they are signifying one subtype of arteriosclerosis, and this is arteriosclerosis. Okay. In arteriosclerosis, the one thing that we need to keep in mind is it occurs in elastic arteries, large arteries, and muscular arteries. Okay. All of this is why I had the basic slide. Okay. Just so we're all familiarized with all these terms. Okay, so elastic arteries, muscular arteries, and large arteries. Okay, so essentially the small, the large, and medium ones. Okay, now what are these two? What is this finding seen over here in the gross version? Fatty streaks. Okay, these fatty streaks. This is what they look like under the microscope. I'm sorry. This is what they look like under a microscope, and they are primarily made by the presence of foamy macrophages. And all of this will be discussed in a little bit when we talk about the pathophysiology. Now, the deposition and the risk factors that come with arteriosclerosis, they include hyperlipidemia, hypertension, diabetes, and so on, so forth, smoking. So the deposition of all of these, of all of the substances that are related to these risk factors into the arteries will lead to something, to the formation of this appearance. Okay. So yeah, this is just another view of fatty streaks. As we know, fat under microscope, it appears white, and this is why it's so easy to identify it under a microscope, because a fatty streak is white because it has depositions of fat. Okay. Now, moving on to the pathophysiology, this is just a simplified overview of what happens. So the first thing that happens is chronic endothelial injury. Okay, so when there's chronic endothelial injury, the endothelium, due to any of the substances that we just talked about. So we have lipids, we have smoking, hyperlipidemia, smoking, hypertension, so on and so forth. All of this will lead to endothelial damage. And this endothelial damage, once due to the chronicity of it, because of how much it's happening, it's going to lead to endothelial dysfunction. And when there's so much endothelial dysfunction, monocytes and lymphocytes will start to get recruited into the wall of the arteries, the arterial wall. Okay, and it's going to start to form fatty streaks, and lastly, fibrous plaque formation. Okay, we're going to get into the details of that in a little bit, but just keep this in mind. This is just a quick rundown. Okay, now these are all pictures that you all are familiar with. Just in a little bit more detail, we said that's due to chronic endothelial injury because of the risk factors that we talked about, hyperlipidemia, hypertension. It's going to lead to endothelial dysfunction. This endothelial dysfunction will increase the permeability of the blood vessels, and thus the monocytes and all the WBCs that were recruited to the site will enter the arterial wall. Okay, then there will be a smooth muscle recruitment, and this smooth muscle sorry, I'm really sorry. Okay, so we have macrophages and smooth muscles with hyperlipidemia and hypertension. This will lead to the formation of foamy macrophages. Foamy macrophages are essentially macrophages with lipid deposited inside them. Okay, lipid will also get deposited into the smooth muscle cells. Okay, and it's going to give this appearance. Okay, and because of the fact that all of this lipid is being deposited into everything that is migrating into the arterial wall, it's going to give the appearance of a fatty streak. Okay, there's so much lipids inside the arterial wall even. So it's going to give the appearance of a fatty streak. Now, as time moves on, there will be a layer of smooth muscle cells forming around the macrophages and the smooth muscles that were here. So all of this, over time, there will be a layer of smooth muscles, such as this one, forming over it, okay? And then the endothelium over it. You know what I mean? This all is called a fibrofatty atheroma, okay? So an atheromatous plaque. It's going to form an atheromatous plaque. Okay? We're going to talk about this more. Okay. Now, which layer specifically we're talking about when we say a fibrous cap or a fibrofatty atheroma? Of a fibrofatty atheroma. We're talking about this layer of smooth muscle specifically. This is an OSPE question. Please, this was repeated a lot of times, so keep it in mind. When we're saying a fibrous cap is formed, we're not talking about the endothelium layer or this thin layer of cells. We're not talking about it. We're talking about the layer directly beneath it. This is the fibrous cap. Okay, so it's the layer of smooth muscles directly underneath the endothelium. Okay, tamam. So that's it for the pathogenesis of atherosclerosis. Now, when we look at it under a microscope, we have the Mason's trichome stain, and we have the elastin stain, and we have the Echenese stain. Okay, so under Mason's trichome, the main thing that it shows us whenever we do this technique is fibrosis. Okay, so if there's blue, that means there's collagen. That means there's fibrosis. Okay, and yeah, okay. So this is essentially what we're seeing in this picture. Under the elastin stain, what we're seeing is that there will be decreased in the number of elastic tissues in atherosclerosis, or elastin layers in atherosclerosis. And why is that? It's because of the multiple endothelial dysfunction. It's going to lead to the breakdown of the other layers as well, which will be replaced by lipid as time goes on. Okay, so under Echenese stain, what we see is two main things. Cholesterol crystals over here, and macrophages just surrounding the lumen, and also any blood vessel, smooth muscle layers or fibers. Okay, so that's it for atherosclerosis. Now, one of the things that can be a further classification in terms of the fibrous cap, it can either be a vulnerable fibrous cap or a stable fibrous cap, or vulnerable atherosclerosis and or stable atherosclerosis. Why is it vulnerable and why is it stable? And in this type, the fibrous cap, which I said is, as I said, is the smooth muscle layer over here, is really thin. This means that it's susceptible to rupturing at any time. okay? And if it ruptures, it can lead to many other things. And if it's, however, if it's stable, that means that the fibrous cap, the smooth muscle layer, is thick enough for it not to have any susceptibility to rupture, which is not good. So yeah. Now, these two, rupturing of any kind in arteriosclerosis is a complication, as we know. This complication of rupturing can happen with a lot of factors, due to a lot of factors. It can happen due to embolization, neural thrombus, or even wall thickening, okay? Especially when it's a vulnerable, if the fibrous cap is vulnerable, this means that it's a vulnerable arteriosclerosis, it's more prone to rupturing, okay? So here, this is a rupture without hemorrhage, with hemorrhage, and this is one without hemorrhage. As you can see, this one has the formation of a thrombus over here, which is not good, and this one doesn't have anything. Now, before we move on, just a couple of things to keep in mind, explained by this chart found in your slides. You can either have an aneurysm and a rupture, and this is due to, as I said, embolization or wall weakening can lead to that, a rupture of the entire vessel wall, okay? Or occlusion by a thrombus. This can be due to this, like rupture with hemorrhage of due to the vulnerability of the fibrous cap, or critical stenosis of the vessel, okay? Critical stenosis of the vessel occurs due to the fact that the plaque formation would be very, very thick and big, okay? So the lumen, as it says, progressive plaque growth. The lumen of the vessel will be very, very narrowed, it's critical stenosis, okay? Now that we're done with atherosclerosis, we're moving on to Mockingbird medial sclerosis. Now this is not clinically significant, however, it's important enough, especially for your OSPE. The main thing that you see over here is the calcifications. They're very, very prominent, and they occur in muscular arteries. So essentially middle or medium-sized arteries. So yeah, these are calcifications that occur in Mockingbird medial sclerosis. From its name, it's in the middle medial wall, like the middle layer, medial layer of the blood vessel. Then you also have fibromuscular intimal hyperplasia. This is transmural. It's non-atherosclerotic, and it's driven by inflammation and or mechanical injury, okay? And it can lead to stenosis of the vessel if it continues on, or if it's chronic. Okay, we have these two images. Does anyone have an answer to what they signify? Okay, so exactly, it's an aneurysm. This is what it looks like under gross view, and this is what it looks like under microscope. Now, if you look at the normal microscope, you can see that everything here is uniform. Now, what are we looking at under the microscope? It's the elastic layers of the blood vessel that we're looking at, okay? Or we're examining. Now, under normal circumstances, the elastic layers will be uniform, okay? However, when we have an aneurysm, the elastic layers would be all haphazard and not very uniform, as you can see here. And under gross examination, this is what it would look like. Essentially, it's an abnormal dilatation of the vessel, okay? And this is a clinical scenario. Take your time. We have a 35-year-old man. He has a 2-year history of worsening right leg pain, exacerbated by walking even short distances. On examination, his right femoral, popliteal, and posterior tibial arteries pulses are absent. His total cholesterol is 430, and his HDL is 22. His CT angiogram is shown. What is the CT finding? as you guys might have guessed. It's going to be the right iliac artery. Okay, there is a right iliac artery aneurysm. Okay, and as I said, what an aneurysm is an abnormal arterial or vessel dilatation. Okay, now in order to further classify aneurysms, we're going to have to look at its types. Okay, now this is a very, very important picture. Okay, it's always in your past OSPEs, so keep it in mind and study it. It's fairly easy. So we have true aneurysms and false aneurysms and dissections. Okay, so in true aneurysms, we have two types. We have the saccular type, which essentially means that there's a sac-like structure in the vessel. And as we know, sacs are only can only be found on, or generally whenever you carry a sac, it's only on one side. Okay, this is how I like to remember it. So if it's saccular, it's only on one side. If it's fusiform, it's on two sides. So both sides of the vessel wall will be dilated. If it's a false aneurysm, what this means essentially is the fact that there's a rupture of both layers. Okay, so there's the endothelial, or all three layers actually. The endothelial layer, the middle layer, and the outer layer. Where the blood is being accumulated is in the extravascular connective tissue. Okay, and it creates a hematoma. Okay, now this is it for false aneurysm. Essentially, it's not the vessel itself is being dilated. However, due to a rupture in the vessel wall, this is where the blood is being accumulated. I hope that makes sense. However, in dissection, only one layer is affected. The first layer, the endothelial layer. Okay, there's a tear in the intima, and this tear will allow blood to accumulate in between these two layers. Now, because there is nowhere else for the blood to go, it might even descend or continue descending downwards. So this accumulation or extravagation of blood into these two into this blood vessel wall might further be exacerbated when it moves downwards. When this blood being collected moves downwards along the vessel, which is not good. It's gonna makes the symptoms much worse and the pain much worse. So just note the differences. If you find it hard to memorize the images, just note the differences between the layers, which one is rupturing and which one is affected. Okay, and yeah, that's it. Just make sure you memorize it. Now, in aneurysms, there are three main types: the abdominal aortic aneurysms, thoracic aneurysms, and perianeurysms. Now, one main syndrome is connected to all three of them, or is found in all three of them. Marfan syndrome. Okay, so Marfan syndrome can see abdominal aortic aneurysms, thoracic aortic aneurysms, or perianeurysms. Okay, now the most common out of all of them is abdominal, and in abdominal, the most common type is fusiform. That's all you need to know. For the OSPE part. Thoracic aneurysms, the most common thing associated with it is hypertension. This is why the most common cause. And then perianeurysms. Under perianeurysms, don't mind the percentages that you see in this picture. However, keep in mind the order of most common site to least common site. Okay, so the most common site for a perianeurysm to happen is the anterior communicating artery. It's 40. The anterior cerebral artery. I'm sorry. The anterior cerebral artery is 40%. Okay, and then you have perianeurysms occurring in the middle cerebral artery, and then you have perianeurysms occurring over here, and then you have perianeurysm occurring in the basilar artery. So just keep them in mind in terms of most common to least common, and you don't have to mind the percentages. Okay. Now, in section, as we mentioned before, is just extravagation of extravasation of blood into through one layer. Okay, because there's tear in one layer. Now, there are types for dissection. Okay, so we have type A and type B. Under the DeBakey classification, we have type A and type B. Type A includes both type 1 and type 2, DeBakey 1 and DeBakey 2. How I memorize it is that type A for ascending. So type A always includes the ascending aorta. Okay. The first one includes both. Okay, so both ascending and descending aorta. Sorry. And the second one includes just the ascending aorta. However, both of them include the ascending because it's type A. Okay. In type B, for how I remember it is B for below, so only the descending aorta, B below, so it's not the ascending. Anyways, I hope that helps anyone. And anyway, essentially, yeah, so the BK 3 or type B is just the ascending aorta part or in the section in the descending aorta. Okay? Keep that in mind. So for this one, what do you guys think? You have a young Asian woman coming to you with temporal pain. So you have giant cell arthritis, okay, or temporal arthritis. Essentially, in this disease, what you have is narrowing of the major branches of the aorta, and this leads to the accumulation of blood in the peripheral blood vessels. Okay, especially the ones that are ascending. Okay, now under microscopy, the main findings are under elastin stain and H&E stain. Under elastin stain, you have the fact that the internal elastic lamina is ruptured. Okay, and this makes sense because of the fact that there's a lot of blood being accumulated to the point where it leads to rupturing of the elastic lamina. Okay, and this just means when it's getting more severe and it's spreading. Okay, under H&E stain, you have the I'm sorry. Okay, so you just have because of the fact that blood keeps on being accumulated in these vessels in large amounts due to stenosis in the major vessels or the narrowing, thrombi, they're very common. Okay, so the red part here is just a thrombus being involved. Okay, now what do we have over here? Okay, this lady is coming to you with a complaint that she can't really feel her pulses. So you have Takayasu. Okay, so Takayasu is another name for it is pulseless disease, and you have intense mononuclear inflammation of the media and the adventitia. Okay, and this leads to giant cells, patchy necrosis, and granulomatous inflammation. Okay, if severe, and if the ophthalmic vein is affected, it can even lead to blindness. Okay, this one we have polyarthritis nodosa. Okay, so in polyarthritis nodosa, the main symptoms are fever, weight loss, malaise, and in the center of the vessel, you will see the formation of a thrombus. Okay, and the pink areas around the vessel will signify fibrinoid necrosis. Okay, and in the matrix or in the ECM around the vessel, you will see a lot of lymphocytes, a lot of collagen deposition, and all of this is because of the inflammation that's happening. Okay. One thing to keep in mind is that this disease spares the pulmonary circulation, so there will be no pulmonary symptoms. Sorry. Okay, moving on. You have a kid coming to you with strawberry tongue. What do you suspect? Exactly, Kawasaki disease. Essentially, it's disease of the children, as you can see. Um, the most common thing that triggers it is a viral infection, and you will see signs of erythematous palms, erythematous soles, mouth lesions, as you can see here, and strawberry tongue. Okay. And lastly, or next up, we have very easy, leukostatic cholangitis. Okay. Um, okay. What you can see under a microscope is the fact that it has fragmented neutrophils. So all of these purple looking dots are neutrophils, and you can see that they aren't really circular as what we're used to seeing them usually. So they're fragmented, essentially. Okay, and it's PNK positive. That's all you need to know for OSPE. Okay, now you have this image um, coupled with this one. Okay, under gross view. Okay, so what do these usually point to? Wegener's granulomatosis. Okay, um, this is C-ANCA positive. Okay, and then usual triad for it is acute necrotizing granulomas of the upper respiratory tract, necrotizing vasculitis affecting the small to medium vessels, and you have crycentric glomerulonephritis. Okay, this is the triad that highlights Buchner's granulomatosis. Okay, under histology, you see multiple granulomas surrounded by a zone of fibroblastic proliferation with giant cells and lymphocytic infiltrate. You have lymphocytic infiltrate all over here. You have giant cells, okay, and you have granulomas. Okay, now in GPA, which is another name for Buchner's granulomatosis, you have other manifestations which include palate ulcerations. Okay, it can be either in the nose or in the pharynx. Now here it's in the palate. Okay, or the top of the mouth. Okay, now this is in its beginning stages, and this is in its later stages. It can go if it goes on for a long period of time. Under chest X-ray, you'll have both two main findings. Okay, so cavitations and fibrosis. These cavitations are very, very clear on this X-ray. You have this one over here, this one over here, this one over here, so you have a lot of it. And fibrosis, it can mainly be seen with the whiteness over here. Okay. Now, these two images are really repeated in your OSPE, so make sure you are aware of them. Now, this disease is Strauss, and it's mainly involved with asthma, allergic rhinitis, all of these things associated with atopy. Okay, and the main finding that you will find is eosinophils. Eosinophils, from its name, they're red in color, so you can easily differentiate them in this picture. And you will have multiple ulcerations under a gross examination. Okay, so as you can see, it has skin involvement. It also involves the heart and has heart manifestations. But yeah, this is all you need to know. And also, it's PNK positive. Okay, moving on to one of the more miscellaneous topics. What does this manifestation tell you? Which disease is it signifying? Berger's disease. So Berger's disease, or thromboangiitis obliterans, it's essentially an inflammatory disease, and it causes destruction of small to medium blood vessels. Okay, the pulses will be decreased or absent, and it's related to long-term history of tobacco use. Okay, so yeah, this very, very nice image that we all know. Okay, it signifies Raynaud's phenomenon. So Raynaud's phenomenon is essentially due to the vasospasm of the arterioles, and it always has to occur bilaterally. Now, the difference between disease and syndrome, or Raynaud's disease, Raynaud's syndrome, I'm not going to be discussing because it's not relevant to your OSPE. However, just keep it in mind. Okay. Review it from your slides, essentially. Now, we're done with the vessels. Moving on to the hard stuff. Okay. So what do we have here? It's very flaky, it's very dry, it's very fibrinous. So we have fibrinous pericarditis. It's the most common type of pericarditis, along with serofibrinous, serofibrous. And what we see on gross view is essentially, as I said, dryness and granular roughness. Okay. On auscultation, there is a very loud friction drop that you hear, and a lot of pain with patients. Okay. In fibrinous pericarditis, under microscopic view, from its name, there's a lot of fibrin. Okay, under microscope, that can be seen as well. So just keep that in mind. Now, we have another type of pericarditis. The main thing that we need to use as identification points in this histology is the abundance of WBCs. Abundance. So what do you have? Neutrophils and dilated vessels. So this is purulent pericarditis. Purulent pericarditis, from its name, it's purulent. So most likely it happens due to inflammation from an infection from a microbe. Okay. Oh, sorry. Okay. This infection can happen due to a lot of microbes. Most common is pneumonia. They present with signs of fever, chest pain, spiking temperatures, and yeah, there will be elevated jugular vein, or yani jugular vein distension. And if you do thoracentesis, pericardicentesis, it can be used for testing later, and it's going to show purulent fluid. Okay. Now, moving on. This is a flower-shaped thing under gross examination. What would it tell us? It's a myxoma. Okay. A myxoma is essentially a tumor, and it's the most common primary tumor of the heart in adults. Okay. It involves chromosomes 12 and 17, and it's most likely associated with the left atrium. Okay. Now, under histology, you have two main findings. You have mucopolysaccharide ground substance, which is essentially the background. Okay. It has a lot of mucopolysaccharides, which is why it's light pink. And you have stellate cells. These are the stellate cells. Okay. These two. Okay. Now, that's all you need to know. Now, another disease that mostly occurs in children is this one. Does anyone have any idea? Exactly, it's rhabdomyoma. Rhabdomyoma, this one mostly involves the ventricles, as compared to the other one, which usually involves the atria. Okay. Under histology, which is more important than the gross examination, you will see gray and white, gray-white cells. Okay, So you see gray white cells and the usual hepatocytes because it myocytes mostly. And this is because of glycogen deposition. Okay, so this is why it appears white. So yeah, so the myocytes will either appear white or pink. And there's also spider cells. Now, spider cells are these dark shaped cells. Okay, when they accumulate together, they kind of look like a spider. You're gonna have to really, really squint. Just memorize. It's called spider cells. Okay, and also the myocytes, they don't usually, like, normally they're not this enlarged. So there's enlarged myocytes. They're glycogen deposition, and this is why some of them are white in color. And you have spider cells. So 3 main identification points in rhabdomyoma. Now, you have someone coming to you to the ER complaining of chest pain. This is how it looks like. This is what the muscle, the myocyte looks like under microscope in the beginning. Okay? You have an MI patient. Okay? So an MI patient, at the beginning, if you look at the cardiac muscle, or if you take a biopsy of the muscle and you look at it under a microscope within the first day, you will only see coagulative necrosis, wavy fibers, and neutrophils. Now, these neutrophils are purple in color, as you can see here. And wavy fibers, these are the myocytes. When they get broken down due to necrosis or whatever, this is the shape they take. And you see a lot of spaces between this layer and this layer. That's because of the coagulative necrosis. Essentially, there's more edema. Okay? Now, after a lot of days and after this MI essentially gets resolved, so we're gonna talk about this in a minute. However, so after the MI gets resolved and under trichome stain, we're gonna see this. So a lot of collagen, a lot of fibrosis in the cardiac muscle, and the myocytes are in between. Okay, the circles. Okay. Now, this series of pictures are so important. Please memorize them. What each one has and what each one, in terms of length, amount of days, findings, and we're going to talk about all of them, okay? Before we dive in, just look at the gross picture. Grossly, you will see yellowing. That's because of the infarction and the broken down collagen. When you look at it for gross examination, it appears yellow. Okay, so this is why. Now, starting with A, we discussed it before. You have wavy fibers, coagulative necrosis, and the presence of neutrophils. That's it. Okay. In B, you will have even more neutrophils, and this is from day 2 to day 3 of the infarct. This is day 1. This is the first day. Okay. Day 2 to 3 of the infarct, you will see a lot of neutrophils, and in between the cardiac myocytes. Okay. For picture C, it's going to be 7 to 10 days after the MI occurs. And essentially what you will see is the removal of the necrotic myocytes that were affected in the initial MI, and the introduction of a new type of WBC, the macrophages. Okay? Now, in D, you will have more blood capillaries being formed, okay? And you'll have more fibrosis being formed. So the deposition of collagen is very evident. Now, these 3 are H&E stains, and these 2 are trichome stains. And as we said, in trichome stains, the main thing that we're seeing is the collagen deposition, because we're trying to look at fibrosis, okay? This collagen deposition starts to occur from 10 to 14 days after the MI, okay? So essentially what I'm saying is that picture D is at 10 to 14 days. Okay, you have granulation tissue being occurring, or any granulation occurring, and the introduction of capillaries. In E, this is post MI, it's healed, and you have just collagen and fibrosis all over. Okay, it's a scar at this point. Okay, yeah, after an MI. So essentially 2 months or 1 month after. Okay, now whenever you have an MI and you are rushed to the ER, they usually give you oxygen. When that MI heals, you will still get injury. This injury is due to the fact that whenever you introduce oxygen, the endothelium of the blood vessels will contract. Okay, and this can lead to hemorrhage because oxygen is not a vasodilator. Okay, it's a vasoconstrictor. So whenever it gets introduced very rapidly, it leads to constriction and it can lead to hemorrhage. Um, um, okay, well, that's it. And edema also occurs. But there's, because of the fact that because of all of this happening, the edema, the reintroduction of oxygen into the system, the color of the myocytes will not appear as yellow. It's going to appear as brownish in color. Okay, and the hemorrhage contributes the most to this color change. Okay, now you will have under a microscope, you will have, as I said, hemorrhage between the myocytes. You will have the arrow is signifying something that's called contraction band necrosis. Okay, so essentially, the contraction of the sarcomere when the MI was happening. I'm sorry, when the oxygen got reintroduced into the body, will lead to this kind of finding. Okay, so the sarcomere will start contracting due to the fact that there is more calcium now when the oxygen got reintroduced, and it's going to lead to the finding of contraction band necrosis. Just, it's going to be insanely, or increasingly eosinophilic. Okay, just keep that in mind. You don't even have to understand the pathophysiology. I just thought it was interesting to say. Just know that you have hemorrhage, contraction band necrosis, and that's it. Okay, and this is happening due to hemorrhage. Okay. Now, complications of MI is also a very, very important series of images that always shows up in OSPE. So starting with picture 1, what do we have here? Okay, we have a myocardial rupture. B is a ventricular rupture. Now you can argue in both of them are rupture in the ventricles, but just to have a difference. It is essentially myocardial rupture. This is specifically in the ventricular wall. Now this one is papillary rupture or dysfunction. D is fibrinous pericarditis. We discussed this before. And E is a mural thrombus. If you can't see it, it's the little like clot of blood that the white arrow is signifying. And lastly, we have F. It's signifying an aneurysm. Okay, a ventricular aneurysm. Okay. Okay. So when you look at it under an ultrasound, pulmonary embolism will be around the left. Will be this is what it will look like. When you look at it under an ultrasound, a pulmonary embolism will essentially look like this. It's a little blurry. This is how it was in your slides. And yeah, just keep this picture in mind. I doubt that we'll ask you about this, so this is just for the sake of completion. So yeah. we're going to look at the vessels in terms of angiograms. Now, generally, you will either have stenosis or occlusions. Okay, here there is an occlusion, specifically over here. Okay, so as you can see the difference between the two, when there's an occlusion, there's total blockage of the perfusion of the organ. In this case, it's the heart. Okay, so that's it for that image. They fixed it and it got reperfused. Here, there's an occlusion over here. After getting fixed, or after they put a stent in and they resolve the occlusion, there's reperfusion of the heart or the organ. Okay, now when there is stenosis, that means when there is narrowing in that vessel. There is still blood going to the other side. However, it's very minimal, and we need to fix them because we need optimum blood perfusion at all times. So after it got fixed, this is how it looks like right now, and this is just another example of stenosis. Okay, you can tell that there is stenosis and there is blood going to the rest of it. However, it's very minimal. And in this picture specifically, there's more than one place. There's this place, there's over here. Okay. Now, Shahid will take over in valvular heart diseases.
Assalamu alaikum, everyone. My name is Shahad Murshid. I'm a fourth-year medical student, and today, alongside Ghedaa, we will be covering your your OSPE portion of your CVP exam, inshallah. And I believe this will help you in all of the components, inshallah, even your MCQs, because you do get a lot of pictures, and we'll be focusing on the high-yield keywords that you should look out for and all the high-yield pictures that get asked about. I included every picture and all the information from your CPCs, all the pictures from your pathology lectures, the most important things in your micro lectures, and micro labs, everything related to the diseases I have in my portion. That will cover the rest. And anything that came in past was included. So inshallah, this should be very inclusive, even more than just your OSPE. So focus in this session. I know it's 2 days before the exam, but inshallah, we'll try to keep it very to the point. And if you have any questions, don't hesitate to contact me, please. And without further ado, let's get started. Bismillah. So valvular heart diseases. Now valvular heart diseases, you have, you can basically, the question tells you a lot based from the question stem and also the pictures. So I'm going to show you how you can get the most of both of them. So this is a long question. We only have a picture, so we're going to go based on the picture for now and see what the question is asking. The question is asking us, what is the diagnosis? We can answer this just based on the picture. We see an aortic valve and it looks calcified. And the aortic valve has 3 cusps. In this case, it's calcified. So we can say this is a aortic stenosis case. However, exactly what is the definition, what is the cause of it? It is senile, because now you can go back to the question and see that this is a 75-year-old male. So this is senile calcific aortic valve, which is basically due to wear and tear, age-related wear and tear. Next question is asking for pathophysiology. So try to answer it and I'll explain. So the pathophysiology of this is basically, as I said, age-related wear and tear. So as your heart muscle starts, you start getting older, your heart muscle was like more and more used and pumped more blood throughout your lifespan. And this puts it at risk for being more stenosed. And basically it gets calcified and then stiffens and then it gets stenosed so that it's more difficult for the left ventricle to push blood into the aorta. And this causes a outflow obstruction from the left ventricle. Blood starts pooling into the heart and could eventually go into the pulmonary vasculature and could cause symptoms of pulmonary edema. So if you look at the question now, you can see these symptoms. You have shortness of breath, you have productive cough, there is chest pain. So all of these are symptoms of pulmonary edema or pulmonary involvement. And It also tells you that there is a systolic murmur. So your murmurs can be systolic or diastolic, or it can cause systolic dysfunction or diastolic dysfunction. And it depends on which stage of the cardiac cycle this happens in. So it affects mostly. So in aortic stenosis, the part of the cycle that's most affected will be systole, which is when the heart is contracting, because the left ventricle wants to contract against a stenotic valve. So in this case, aortic stenosis causes systolic dysfunction or an aortic or a systolic murmur, sorry. And likewise, when the heart is contracting, you can think of it going in two different ways. So it could either go up into the mitral valve or it can go forward into the aortic valve. So if it goes up into the aortic mitral valve while it's contracting, this would be mitral regurgitation. And if it can't go forward when it's contracting, this would be aortic stenosis. So the two main causes of systolic murmur or systolic dysfunction is aortic stenosis and a mitral regurgitation. So keep those two in mind. Next question. Oh, this is not a question. This is just showing you a calcific aortic valve. So you can see the aortic valve with these calcifications. You can get either of these pictures, so focus on them. Now, diagnosis. This is mitral annular calcification, which is basically calcification in the annulus of the mitral valve. And you can see them here, pointed at the arrows. Now, what is this? This is your normal, and then it became into this. This is myxomatous degeneration. This can happen in Marfan syndrome. So what is myxomatous degeneration? This is basically when the mitral valve leaflets and the chordae tendineae, they start to undergo degenerative changes, and the fibrous tissue in the heart, the normal fibrous tissue in the heart, starts to get replaced by something that is more loose and like gelatinous, which is myxoid basically, which gives it the name myxomatous degeneration. So you start getting myxoid, replacing the fibrous tissue, and this causes the valve to be very floppy, and the chordae tendineae become very weak, so they're not able to hold the valve properly. And this causes mitral valve prolapse. So myxomatous degeneration is a finding in mitral valve prolapse, and it can be seen in Marfan syndrome. Now, what is this? Again, this is mitral valve prolapse. Mitral valve prolapse is basically ballooning of the mitral valve into the atrium. So ballooning is like your keyword, and also it just looks it looks like it's protruding upwards. So like when it's trying to contract, or if it wants to close, basically the high pressure in the ventricle will cause it to balloon upwards. And here again, you can see these are like thrombosis, and this is the mitral valve prolapsing. Know these images well, please. Okay, now what is this? This is mitral valve stenosis with a fish mouth appearance. So there are different things that can cause mitral stenosis. One of the more important ones, or relative to you, is rheumatic heart disease. And we're going to talk about it later, but just keep that in mind. And you can see that the valve is so stenosed that it's almost closed and it looks like a fish mouth. Again, another keyword, fish mouth appearance. So here, what is the diagnosis? Here we have acute rheumatic heart disease. Now, in rheumatic heart disease, what happens? Basically, you have the M protein of strep pyogenes. It mimics myosin in the heart. So it binds to it and starts attacking it, and the heart starts getting damaged. And from this, the endothelial layer gets damaged, and you start getting inflammatory process, like the inflammatory process starts in the valves, and you start getting platelets, thrombus formation, everything to help keep the endothelium layer intact. And this makes verruca form, which is what you can find here. So these are verruca, and they are not caused by bacteria. They're not non-bacterial. They're sterile vegetations of the heart, and it can be seen in acute rheumatic heart disease. Now, histologically, what can you see in acute rheumatic heart disease? You can see two main things. First is this here, which is an Ashkoff body. And then within the Ashkoff bodies, you have what is called NH-CoA cells, which are basically like reactive histiocytes. And yeah. What are the clinical features of, let's say, rheumatic heart fever, not disease, rheumatic fever? This would be the Jones criteria. So you'd have joint problems, hearts, you'll have pancarditis, subcutaneous nodules, erythema marginatum, Sydenham chorea. Remember these very well. They could ask it to you as like a follow-up in the OSPE. This is just a summary of the symptoms. Now, here, what is the diagnosis? This is chronic rheumatic heart disease. So in acute rheumatic heart disease, first of all, in rheumatic heart disease, what valves are most affected? Mitral valve mostly, and second is aortic. Tricuspid is rarely affected. So mitral valve, in the initial stages of the disease, you get mitral regurgitation. As the disease progresses, you start to get mitral stenosis, and then eventually also aortic stenosis. So in chronic rheumatic heart disease, if you see aortic stenosis, you will have something called, if you know, without looking at it, it's fusion of the commissures. So over here, you can see, okay, wait, let me show you one where the commissures are not fused. Over here, for example, you can see that there is 3 cusps. However, here there is a space between these two. They're not fused. There is this black space in between them that shows you that they're not fused. However, if you look here, in chronic rheumatic heart disease, you have fusion of the commissures, so they start fusing together. And this is how you differentiate aortic stenosis that is due to wear and tear versus aortic stenosis that is due to chronic rheumatic heart disease. In chronic rheumatic heart disease, you'll have fusion of the commissures and coexisting mitral stenosis. Because as I said, mitral stenosis is what happens first. It's the main valve, main valve that's affected is the mitral valve. And then you can have aortic alongside it. So here, this is chronic rheumatic heart disease, where you can see aortic stenosis and fibrosis and commissural fusion, as I said. Okay, next. Which of the following shows mitral annular calcification? We already discussed this. C. Okay, this is just a summary of all of the causes of murmurs in the heart, systolic and diastolic. I'm not going to go over it, but I really want you guys to master these because they can tell you so much in a question. They can give you the answer immediately just by a process of elimination if you know the keywords in each murmur. So go over this in your own time. Okay, now we're done with the valvular diseases. Now we're going to talk about infectious, inflammatory, and cardiomyopathies. So to begin, which of the following is associated with SLE? C. What is C? Liebman-Sachs disease or Liebman-Sachs endocarditis. This is easy to remember because SLE, LSE sounds the same. But you can also get this in a question and they will describe the symptoms of SLE, such as, or like findings such as the ANA antibodies or the double-stranded DNA, all of that. So they would describe the autoimmune findings in SLE. And this picture is very important. So just so we can go over all of them. This one is infective endocarditis. Infective endocarditis is due to bacterial vegetations or bacterial invasion. So it's basically the bacteria attacking the valve. So this is why this looks very messy. The valve is all, this is like the chordae tendineae start ripping and there's these like friable vegetations. In rheumatic heart disease, as I said before, these are verruca or sterile vegetations that are lining the heart valve. In Liebman-Sachs endocarditis, very important about it and unique to it is that it occurs on both sides. This, you cannot see it in any of the other vegetations. So this is Libman-Sachs. And then you have NBTE, or non-bacterial thrombotic endocarditis. This, from the name, is non-bacterial. The vegetations are sterile, and they can easily latch off and become an emboli and go other places. So from the name, it's thrombotic. And as I said, they are not adherent to, they're not like strongly adherent, so they can easily come off. This is an important feature of it, that's why I'm mentioning it. Okay, so here, what is the diagnosis? Acute infective endocarditis. And how would we know that this is acute and not subacute? Acute is much, much worse. It is much more invasive. It causes a lot more symptoms, and it happens much more rapidly. And it forms what's called ring abscesses. So this is a ring abscess formed in acute infective endocarditis. So which of the following is the causative organism for the previous patient? That would be A, which is Staph aureus. You can see the golden colonies that describe Staph aureus. So in Staph aureus endocarditis, the main things that I want you to remember is that it is mostly seen in IV drug abuse. So whenever you see a case that is describing someone with IVDA, whether they're explaining the intoxication symptoms, or they tell you they have needles in their needle markings in their arm, immediately think of IV drug abuse and think of Staph aureus. And when you think of that, also think of it affecting the tricuspid valve. Tricuspid valve is very rarely affected except in cases of IV drug abuse. Why is that? It's because the vein drains into the right side of the heart, and the first valve that it's going to encounter is the tricuspid valve. And importantly also, it affects previously healthy heart valves. Again, this is because of the very high virulence of Staph aureus. So it doesn't need a valve that's already, the endothelium is a bit damaged due to other conditions in order for it to cause severe symptoms. It can infect even healthy hearts. And this is in comparison to something else. We'll talk about it. So the features of Staph aureus. This is a summary slide from every single thing I found on Staph aureus, whether it was past, micro, patho, everything. These are very important to know. So Staph aureus, on blood agar, you can culture it different ways, you can do different tests, all to show you the same result, which is diagnosis of Staph aureus. On blood agar, what would you see? You would see golden colonies. So this is over here. If you do a gram stain, you'll see gram-positive cocci and clusters. We know this. If you do a catalase test, it will be positive or negative? It will be positive. Now, what is a catalase test? It's basically, catalase is an enzyme that converts hydrogen peroxide into oxygen. And oxygen causes all these bubbles that you can see here. So what you do in a catalase test is you basically put hydrogen peroxide and mix it with the bacteria and see if it bubbles or not. If it bubbles, that means, okay, the bacteria has catalase and it converted this hydrogen peroxide into oxygen. So Staph aureus does have catalase, so you will see these bubbly things. For coagulase, if it has the enzyme coagulase and it coagulates the blood, basically, it'll be coagulase positive, and this is what happens here. So Staph aureus is coagulase positive. These are all different ways to show you a coagulase test. So you can get these tubes, know that this is positive, this is negative. Here, this is coagulating. They're like clumping together, so it's coagulase positive. Here, again, coagulase positive. Now, for another agar, we have mannitol salt agar. Now, mannitol salt agar is both selective and differential. It's selective because it only allows Staph species to grow. And that is because of the salt, the NaCl. It's differential because it differentiates the different species of Staph based on their ability to ferment mannitol. So if it ferments mannitol, it will become yellow. If it doesn't, it'll remain pink. So Staph aureus ferments mannitol, so it's going to be yellow. So over here, which one is Staph aureus? The yellow. The other one does not ferment mannitol, which would be Staph epidermidis. So it differentiates those two species of staph. Next, we have Staph epidermidis. Not much was discussed about this in terms of clinical, like infective endocarditis. However, know that it affects prosthetic heart valves. Now, as for its laboratory features, it is gram-positive cocci in clusters, exactly the same as Staph aureus. So if you just see the gram stain, you will not know how to differentiate them. You can't say just based on the gram culture if this is Staph epidermidis or Staph aureus. Next, you have blood agar. Here it shows white colonies on blood agar. For the catalase test, it is also catalase positive, just like Staph. So again, you cannot, just like Staph aureus, so you cannot differentiate it based on catalase test. For coagulase, it is coagulase negative. So this is different than Staph. So if you see coagulase negative and gram-positive cocci in clusters, you can say that this is Staph epidermidis. Actually, it could also be Staph prophyticus, but anyways, this differentiates it from Staph. For mannitol salt agar, this is your main differentiating feature between Staph epidermidis and Staph aureus. Staph epidermidis does not ferment mannitol, so the agar will stay pink. Now, you get this question. A patient is infected with infective endocarditis. A sample of blood is taken and cultured on mannitol salt agar. It is catalase positive. Which image shows the cultured organism? So you have mannitol salt and it's catalase positive. Which of these shows mannitol salt agar? It's A. This is mannitol salt agar, and it does not ferment mannitol, so it's completely pink. There's no yellowing of it, which shows no presence of Staph aureus, and it's catalase positive. So the answer is A. I forgot to put letters. It's okay. Okay, which test is used for the diagnosis of this organism? So this organism here, how would you diagnose it? How would you know exactly what the species is? So here, this tells you that this is gram-positive cocci in clusters. Now I told you, you can either have Staph epidermidis or Staph aureus. So how would you differentiate between them? The catalase test will not help you. They're both positive. B is the CAMP test. This won't help you, again. C is the mannitol salt agar, which we used to differentiate, specifically Staph epidermidis and Staph aureus. So this is what you would use to be able to differentiate it. Because if it was Staph aureus, as I said, it will ferment mannitol. If it wasn't, if it didn't ferment mannitol, it would be Staph epidermidis and it would remain pink. I saw this answered in your OSPE file, and it was, I think they put the answer as A, so I just wanted to clarify that in case someone mistakes it. And this is the optician test, so it doesn't have anything to do with Staph. Okay, so C. Which of the following pictures represents Staph aureus culture? Again, same thing, mannitol salt agar, C. So for MRSA detection, different species of staph, certain species of staph have what is called they're methicillin resistant. So you basically can't use beta lactams on them. And the way that they confer this resistance is by altering the penicillin binding protein, which is what beta lactams bind to in order to cause their toxic effects to the bacteria. So all you have to know from this slide is that it alters the penicillin binding protein and it affects the target modification, which is the one circled here. This was in a past question, so that's why I put it here. You can read the rest, but this is the main thing that I want you to take from this. Okay, another case. Okay, do we want to read it? I think, okay, let's see what we highlighted. We'll focus on that. Okay, so there is a low-grade fever for 3 weeks. So it's not that intense, and it's 3 weeks, which is a relatively long time. We have splinter hemorrhages, we have nodules on the palms and soles, and a murmur. All of this leads us to infective endocarditis because of these symptoms. However, we still want to know what it is, what's causing it. So we will use the other pieces of information to reach our diagnosis, as well as the picture. So it's asking you, what is the organism and what is the diagnosis? So the organism here, who can tell me or answer, please? The organism here would be strep viridans. So strep viridans causes a subacute infective endocarditis as opposed to the acute endocarditis caused by Staph aureus. Subacute meaning the symptoms are not that severe, you get more of a low-grade fever, and it's more long-term, so it does not happen in an acute period of time. Like Staph aureus, we saw it was within a few days. Strep viridans causes endocarditis within a few weeks, as you can see here, 3 weeks. And yeah, so we have the organism and we have the diagnosis. And strep viridans, this is the optician test. Strep viridans is optician sensitive or resistant. It's resistant, so there is no zone of inhibition. Laboratory features, strep is gram-positive cocci in chains. It is alpha or beta hemolytic. It's alpha hemolytic, and we said it's optician resistant. Know all of these features because they can be described in the STEM, in the question STEM. Now, the clinical features of infective endocarditis can be remembered by the mnemonic from Jane. And you have basically like minor criteria and major criteria to diagnose it, but make sure you have that down. So these are the features. Here we have Roth spots, which is like retinal hemorrhages with a central area of necrosis. Osler nodes are these painful subcutaneous nodules. Janeway lesions are painless lesions on the soles of the feet and hands. These are subconjunctival hemorrhages. These are splinter hemorrhages. So these can all be seen in infective endocarditis. So what is the pathogenesis of not infective endocarditis? Specifically, the splinter hemorrhages. So splinter hemorrhages are basically hemorrhages under the nail bed. Now, how do they happen? Basically, you know that infective endocarditis, you have bacteria attacking the valves, causing the endothelial layer to be exposed, causing a lot of platelets, fibrin clots, and more bacteria to come. And all of these together cause vegetations, and then these are able to break off, they go to the peripheries because they're the smallest capillaries. They go into the capillary, the nails under the nail bed. You get immune complexes depositing, you get more inflammation. It's like a vicious cycle, and this causes splinter hemorrhages. This was in your CPC, so you might ask about it. Okay, which of the following should be used to culture for blood? Now, if you get this patient with the symptoms of infective endocarditis that we talked about, you immediately want to send for a blood culture. Now, what would you use? You would use B. Now, why? This is because you want to get a set of 2 or like 3 sets, and each one has to have anaerobic and aerobic. Ghedaa will talk exactly how to collect the samples and everything in the end, but I wanted to include this here because it's related to infective endocarditis. So the sample you would order is this one, not the one with the same colored cap, not a blood bag, not these, the one with 2 and different colors. Please don't get this wrong because they will ask it probably like 100%. Okay, what is this patient's condition associated with? First, what is the condition? This is non-bacterial thrombotic endocarditis, or NBTE. Now, what did I tell you about NBTE? It is not strictly very adherent to the endothelium, which is what you can see here. You can see the space, which shows you that it's not adherent to the endothelium, so that it can easily be like become an emboli and go to different places in the body. And you have these like vegetations along the valve. They don't look too bad. They're sterile vegetations. And what is it associated with? Adenocarcinoma, hypercoagulable states, Trozo syndrome. Okay, these are all syndromes that can cause hypercoagulable states. And if it's a hypercoagulable state, then you're more likely to form thrombi, hence non-bacterial thrombotic endocarditis. And adenocarcinoma, very, very associated with it. Remember it. Remember hypercoagulable states, high estrogen states, anything that can predispose to clot formation. Trozo syndrome, this is a perineoplastic syndrome, basically, that happens with certain malignancies. Just know it. Trousseau syndrome can be associated with non-bacterial thrombotic endocarditis. Okay. Next. What is this? You said dilated cardiomyopathy. You are correct. So dilated cardiomyopathy is basically when the myocytes or the heart starts expanding, but not thickening. So it gets bigger, but you basically have like sarcomere proliferation in a series, not parallel. Parallel, they would be like stacking up on top of each other, hence making the wall thicker. In dilated cardiomyopathy, they are in series. So they are like side by side, which only makes the ventricular wall larger, like a larger surface, or like bigger, not thicker. Okay, so would this cause systolic dysfunction or diastolic dysfunction? The heart basically can't pump strongly because it's not that strong. It would cause a systolic dysfunction. The heart can't contract, so it would cause a systolic dysfunction. This is in comparison to another one, so this is why I want you to remember it. Dilated cardiomyopathy, systolic dysfunction, thinning of the heart walls, and what else? Yeah, the sarcomeres are proliferating in series. Do I have another question here? No. Okay. So these are basically another finding, which is the ninja star nuclei. So again, know how to identify them. So what are the causes of dilated cardiomyopathy? Now, important about dilated cardiomyopathy is it can be either genetic or acquired. The acquired causes can be stuff like alcohol, chemoradiation, like specifically anthracyclines, doxorubicin, daunorubicin. And the genetic causes, it's mostly autosomal dominant, but it can also be autosomal recessive or X-linked recessive. The mutation is in genes that encode cytoskeletal proteins. I hope you guys didn't see it, but I want you to think which genes specifically. So you have titin, dystrophin. Titin is the most common. Dystrophin can be seen in the X-linked recessive form. Lamin A and C, Desmin. These are all important, by the way, because they can ask about any of them. Okay, what is this? So you have here, this gives you a little bit of a hint. It shows you hyperkeratosis of the palms and the feet. And then you have this very thin right ventricle. And you have, again, here it's very thin. So what is this? Arrhythmogenic right ventricular cardiomyopathy. Okay, so arrhythmogenic right ventricular cardiomyopathy is a genetic condition that basically replaces the myocardium of the heart with fibrous tissue and fat. So this is what you can see here. Basically, all of this is adipose tissue, the white, and here this is all fibrosis. Compare it with the normal heart here. Okay, sorry guys, it keeps giving me weird notifications. So this is arrhythmogenic right ventricular cardiomyopathy, and if it coexists with hyperkeratosis of the plantar surfaces of the hands and feet, you have something called Knox-Host syndrome. And Knox-Host syndrome, this can be seen in the gene for this, or the mutation is something called plakoglobin or something like that, in case they ask it. Okay, so here we have diagnosis, histologic features, causes. Think about it. Okay, diagnosis. Okay, this is hypertrophic cardiomyopathy. Now, hypertrophic cardiomyopathy, in comparison with dilated cardiomyopathy, causes a diastolic dysfunction, and the sarcomeres proliferate in parallel. So they stack up on each other, making the wall thick, and then making it non-compliant so that it can't fill properly. So it causes diastolic dysfunction. Histological features. Try to think about it also. When you look at this picture, I know a lot of histology pictures look alike, but look at this picture and try to like remember how it looks very haphazard, wavy. So you have myofiber disarray and fibrosis. These are the main findings and keywords also. And they could ask you to just list the histological features. Now, what are the causes of hypertrophic cardiomyopathy? Now, in comparison to dilated cardiomyopathy, hypertrophic is purely genetic. So what genes could be mutated? You have genes encoding sarcomeric proteins. In dilated cardiomyopathy, what did we have? We had cytoskeletal proteins. Here we have sarcomeric proteins. So we have myosin binding protein C and myosin light chain and troponin. Know these genes very well, please. Okay, next, diagnosis. This is very, very characteristic, very easy to spot. You have amyloidosis. Amyloidosis can happen anywhere in the body, and you'll take it in multiple different blocks throughout third year. Every time you see it, you will see the key apple green birefringence in Congo red stain. Apple green birefringence under polarized light, which is this here. So this, very characteristic of amyloidosis, and it's basically amyloid buildup. So all of this light pink material is all amyloid. Next, we have questions. Which of the following represent a dilated cardiomyopathy? Hopefully you guys said B. This is the arrhythmogenic right ventricular cardiomyopathy. You can see, by the way, I don't know if I said this, but you can see the right ventricle here is very thin. So think of right ventricular arrhythmogenic, blah, blah, blah. Okay. Now, diagnosis. Here we're moving to myocarditis. Okay. Remember all the types of myocarditis? Okay. This is lymphocytic myocarditis, which is just basically caused by viral infections. Importantly, Coxsackie A and B, CMV, HIV, influenza. Please remember these. Actually, it's important to know that this is lymphocytic myocarditis and it's caused by viral infections. Coxsackie A and B are very common, so it could come in the question. But if you get any viral mention in the question, you know it's lymphocytic myocarditis. Now you can see these lymphocytes everywhere. Now this is hypersensitivity myocarditis. The way I like differentiate them is I think of hypersensitivity to where like, okay, you have a problem in a specific part of the body that is hypersensitive. Like a specific thing caused hypersensitivity in this certain part of the body. So they're like, all of these are like running into the, like to save the day. Because they're all like clumped in one area. Whereas here, lymphocytes are everywhere. Hypersensitivity, you see like an area. I don't know if this makes sense, but this is how I've always thought of it. So this is hypersensitivity myocarditis, and it can be caused by drugs like methyl dopa, sulfonamides. Here, what can you see? Giant cells. They're all giant cells, giant cell myocarditis. Very easy to spot. Here we have Chagas disease, caused by trypanosoma cruzi infection. Okay, now these are just a bunch of this is just to show you the different to talk about like the imaging modalities. It's not too important to identify all of these, but remember, mostly for your MCQs, the best imaging modality to visualize tissue structures, like the tissue of the heart or tissue characterization, is MRI. Very important. And then if you want to visualize the valves, an echo is your go-to. First line, usually for chest, anything is x-rays. Okay. Diagnosis. This is cardiomegaly. The heart is more than 50% of the length of the chest wall. Okay, here, what is the diagnosis? This is heart failure. Heart failure specific findings are curly V lines that can be seen on the edge over here. You can also have interstitial markings, which is basically from like blood pooling into the pulmonary vasculature. So you have markings such as these, and then you can have pleural effusion here too, any fluid that's surrounding. So yeah, this is heart failure. Yeah, okay, wait. I don't know why I just did that. Okay. Ghedaa will take over now for pulmonary part of it, and then I'll be back.
Guys, I'm back again, and now we're going to start the pulmonary part of this OSPE. We're going to start with obstructive and restrictive lung diseases. Now, in these lung diseases, we have two types, obstructive or restrictive. The main two obstructive types are emphysema, that are important for OSPE, are emphysema and asthma. Now, emphysema is further subdivided into two types, centroacinar and panacinar. Centroacinar is associated with smoking and or inhaled toxins, and its main mechanism is inflammation. Okay, and because of the fact that it's associated with smoking, just think about it. Air goes up, so it affects the upper lobes. Okay, that's it for centroacinar emphysema. For pan-acid emphysema, it affects the lower lobes. Okay, and this type is primarily due to deficiency in antitrypsin 1. Okay, and restrictive lung diseases, it's another thing. It's subdivided into interstitial lung diseases, which we'll discuss later through the rest of them. Okay, so you have a case of a 60-year-old man. He's a smoker, and he came to you with worsening dyspnea for 5 years. He has been smoking, and he has a hyperresonant note on percussion. Okay, grossly, this is what his lungs would show. Okay, and once we took a biopsy from his lungs, this is what came through. What would you say? We just discussed emphysema. Okay, specifically centroacinar emphysema. Okay, so what is emphysema? Okay, essentially, the number of alveoli walls is increased due to decrease in the amount of elastic tissue, in alveolar elastic tissue. As you can see here in the normal view, alveoli walls are numerous. Okay, there's a lot. Okay, however, here you can tell that a lot of them in a lot of the alveolar walls are broken down. There is large air spaces in it. This makes it hard for the rebound of the lung to occur. Okay. So yeah, so the main mechanism that occurs with emphysema is there's protease and antitrypsin 1 imbalance. Okay, protease comes from all these toxins that come from the body. It gets deposited in the lungs, and they secrete protease. No, anti-protease or antitrypsin 1, they come in and they neutralize all of these toxins. If there is an imbalance in this system, emphysema happens. Okay, that's it. And more explanation can be found in the notes section. Now, emphysema, when you do a chest X-ray, you can find two main findings. Okay, hyperinflation and more hyperinflation. Sorry, flattened diaphragm. As you can see here, this picture shows it more clearly. The diaphragm is very flat. Okay, that's it. So flattened diaphragm and what's called as barrel chest, or an increased in the AP diameter. This picture shows it more. There's, as you clearly an increase in the AP diameter or anterior posterior diameter. And generally, this finding or the increase in anterior posterior diameter is very common in COPD. Okay, and the flattened diaphragm. Okay. Now, specifically, pan-ancilar emphysema, as we said, it's more common in the lower lobes. Okay. Now, under a CT, in a CT scan, it will only affect the lower lobes. So the lower lobes over here are the ones that are affected, and this is why it's specifically pan-acinar emphysema. When we link these stuff together, it becomes easier for you to memorize. So this is why I'm making all these connections. Now, this picture over here, you have, it's related to something that we discussed just moments ago. Exactly, alpha-1 antitrypsin deficiency. Okay, now, alpha-1 antitrypsin deficiency, it does not only affect the lungs, it affects its multi-system. And in this case specifically, it's affecting, we're looking at the hepatocytes. Okay, so there are globules of antitrypsin. One, they're accumulating inside the hepatocytes, and this is what we're seeing over here. Okay, the dark purple accumulations. It's just accumulation of alpha-1 antitrypsin inside the hepatocytes. Okay, and you can also see liver fibrosis. It's not very evident in this picture, but generally it's a identification point. Okay. Now, this disease is usually or related to or associated with central acinar emphysema. Okay, it would be chronic bronchitis. Okay, now in this microscopic picture specifically, the main thing that you can see is mucus accumulation. Okay, that's it. Okay, so now for this upcoming disease, this is how it looks like under gross, and this is how it looks like under CT. Okay, it's associated with cystic fibrosis and brain metastasis. It's bronchiectasis. Okay, there is fibrosis and scarring of the airway walls, and they are filled with neutrophils and mucus, essentially. Under a CT scan, the scarring and the fibrosis is very, very clear, as you can see here. It's more common in the right lung than in the left, but yeah, okay. And under gross view, this is what it looks like. Okay, and as I said, it's associated with cystic fibrosis and brain abscess, metastatic brain abscess specifically. Very easy. This is pulmonary hypertension, okay, and you can tell because the vessels are very dilated. So, okay, pulmonary hypertension, and it usually occurs because of a mutation in the PMPR2 pathway. Okay, just keep that in mind. Now, under pulmonary hypertension, there's chronic thromboembolic pulmonary hypertension. It presents with two main microscopic findings, medial hypertrophy and plexiform lesion. Okay, so under medial hypertrophy, from its name, there's hypertrophy of the medial layer of the pulmonary vessels. And in plexiform lesion, essentially there's proliferation. It's gonna need an artistic mind. Stay with me here. There's a proliferation of the endothelial cells in these capillaries or in these blood vessels, okay, within the blood vessel. So essentially you're creating blood vessels within blood vessels. Okay, and this is what causes this lesion to be brought up in the first place. Okay, just think of it this way. It looks like a Van Gogh painting. This is exactly what I thought of when I saw it. But يعني just think of it like that. Okay, there's endothelial proliferation within the endothelials. endothelial layer. So just stacking them. So yeah, then you have these two findings. Okay, what you see over here is chronic interstitial lung diseases, and these are restrictive lung diseases. Okay, under Gauss view, what you see is honeycomb appearance. Now, honeycomb appearance is a tricky word because it comes up in a lot of findings and a lot of diseases. Okay, just be focused. Okay, in interstitial lung diseases, in chronic interstitial lung diseases, it's a honeycomb appearance grossly. Okay, there's going to be reduced compliance in the lung, and under chest CT, there will be ground glass opacities, which is essentially irregular lines with small nodules, and you can see it very clearly. Okay. Okay. Now here, does anyone know the diagnosis? Exactly. So you have idiopathic pulmonary fibrosis. Essentially, it has a cobblestone appearance, okay, on gross examination, which is not seen here. You will have dry crackles on auscultation, and under microscopic view, you will have patchy inflammation, okay, and fibrosis. So there's inflammation over here, as you can see by the WBCs. They're purple, okay, over here and over here. Now in the middle, you don't see anything. Fibrosis. Okay, so there's fibrosis over here and inflammation over here and over here. Okay, under chest X-ray, you have subpleural fibrosis and honeycombing. Okay, neither of us can see it, by the way. I'm just saying. I tried to look for honeycombing on the chest X-ray and the subpleural fibrosis. I can't find it. Just memorize these findings and memorize this image specifically for idiopathic pulmonary fibrosis. Okay. Now, this is a very descriptive image, and it's even very more descriptive because of the anthracosis called worker pneumocosis. Okay, pneumoconiosis. So essentially, there is, due to the accumulation of coal, fumes, and all of this, it's going to lead to anthracosis of the lungs. Anthracosis of the lungs is essentially the darkening of the lungs, or there's dark pigmentation of the lung. And it's going to lead to, if it progresses for a long period of time, there might even be damage to the function and fibrosis of the lung. Okay? And yeah, that's it. It does increase the risk of cancer. And as I said, due to its, depending on its chronicity, it can be either, it's on a spectrum, it can be either benign or something that can be resolved, or it can affect the lung function by fibrosis and by the process of fibrosis. Okay, now moving on to the next thing. This looks like silica deposition. So silicosis. You have it's your second type of pneumoconiosis. Okay, and it's the most common occupational disease in the world. As I said, it's due to the deposition of silica, and it increases the it increases with the association. It increases the association of TB and cancer. Okay, so TB and cancer. Just keep that in mind. In the left picture, we have over here, you have nodular fibrosis. There's increased pink over here. Okay, so nodular fibrosis, and the light in the right picture, it just shows you the silica. Under a microscope, it's bifringent, so it shines, essentially. It bounces back the light. Okay, and under X-ray, there's nodular opacities in the upper lobe. Okay, over here and over here. Okay. So that's it for silicosis. Next up, you have another type of pneumoconiosis is asbestosis. Okay. Now this type is very important to note because of the fact that it doesn't only harm the person affected or the person working in these places, in the place where asbestos is, but it also can affect the family members because of the fact that it attaches to clothes. Okay, so when you're done, you go home with the clothes that you worked in an environment where asbestos is, it can also affect your family members. Okay, so it causes severe inflammation and fibrosis of the lung, as you can see in the gross image. There's severe fibrosis of the lung. Okay, and it's associated with pleural effusion, lung cancer, and laryngeal cancer. Okay, keep them in mind. Okay, and it's also a carcinogen. One of the things it's associated with is mesothelioma. Okay, so there's 4 things it's associated with: mesothelioma, pleural effusion, lung cancer, and laryngeal cancer. Okay. Now, in microscopic view, you can see these are called asbestos bodies. They're fibrous bodies that are coated with iron. Why they're coated with iron is because of the macrophages. The macrophages, they came to the lung and they found foreign bodies, and they were like, we're gonna have to kill them. They tried to kill them, they can't kill them, but in order for them to kill them, they have to coat them with iron. And when the macrophages died, they left behind coated asbestos. That's it. That's it. That's all you need to know. And this is why it looks like this. This is why it looks reddish or copper-like. Okay? Now, asbestos under a CT scan, there will be pleural thickening with irregular outlines. Okay? So you can see it over here in the red arrow. The pleura is thickened. It's this from here to here. It's really thick. And the outlines for it are irregular, unfortunately. Okay? You can see it on this lung, but you can't see it on this lung. Okay? Just as a comparison. Okay? And you can also have prominent hilar lymph nodes. This I couldn't find on the CT, so just keep it in mind as an identification point. Okay? Now, next up, we have sarcoidosis. Okay? And main point to keep in mind is non-caseating granulomas. Just keep it in mind. Okay? The 3 things that it usually also has is bilateral lymphadenopathy and or lung fibrosis. It also causes ocular lesions and or inflammation of the lacrimal glands in a syndrome called Zika syndrome. Okay. Now, under histology, we have 2 main findings: Showman bodies and asteroids. Asteroid bodies are very easy to identify because it looks like an asteroid. It has a star shape. Okay, and Showman bodies are essentially multinucleated giant cells with calcium concentrated inside them. Okay, that's all you need to know. Okay, now here you have a giant cell in the middle. Okay, and a granuloma. Okay, so it's a non-caseating granuloma plus giant cells. Main thing in sarcoidosis. Okay. Now, under interstitial lung diseases, we have under chest X-ray and under CT scan. Now, as we said before, interstitial lung diseases have a honeycomb-like appearance. Okay. And this is very, very clear under CT scan, even more clear than on the gross virgin, which we discussed previously. Because there are all these circles adjacent to each other. Okay. Now, under X-ray, it's gonna have a web-like appearance. Okay, and it's very clear. It looks like a bunch of lines and a bunch of dots. Okay, over here and over here. Okay, and this is what you can find in ILD imaging. Okay, now that is it for me under pulmonary. I'm gonna come back for MISC and miscellaneous stuff, and that's gonna be the end of the part. See you after Shahad finishes.
Okay, so now we're going to be talking about infections, starting with upper respiratory tract infections, and then lower respiratory tract infections, TB, and then we're going to do cancers at the end. So for the upper respiratory tract infections, the ones in your lectures are strep pyogenes, corynebacterium diphtheria, and Haemophilus influenza. And these are the ones that we're going to be discussing. So starting off with strep pyogenes. You guys probably already know these features, so I'm not going to go into them in detail. I just wanted to have everything in one place for you guys. But what do you need to know about strep pyogenes? It is beta hemolytic. They are gram-positive cocci in chains. Catalase negative bacillus sensitive. These are the diseases that it can cause. It can either be suppurative, which is producing pus, and then non-suppurative. These are mostly like immunologic diseases. And then for diagnosis, the quickest way is a rapid ELISA test for the group A antigens. And then ASO titers for previous infections. And these are some virulence factors. Just know them. And then for corynebacterium diphtheria, the important features in this, also here, this is how it looks like on gram stain. For corynebacterium diphtheria, it is a club-shaped gram-positive rod, arranged in V or L shapes. Like here, they are chromogenic, which is why you have the darkness at the periphery. And they are non-spore forming. The diseases that they can cause include diphtheria. And these are the virulence factors. The main way in which it causes disease is by inhibiting protein synthesis by ADP ribosylating elongation factor 2. That is the exact mechanism that you should know about corynebacterium diphtheria. Now, diagnosis of it is an ELIC test, which is this basically. I don't think it's too important to know the details. I explained it in HNS if you guys remember. But basically, this is the positive control, negative control. This is the test strain. If you see this squiggly line passing through it, then that means it's positive. So the negative control will never have a squiggly. The positive control will have a squiggly going through it. The test will show you whether it'll have a squiggly or not. So this is positive ELIX test. Okay. Now for questions on upper respiratory tract infections. We have this whole scenario. Let's focus on the important things. So we have a 6-year-old boy. Age here is significant. We have the symptoms that he presents with: sore throat, fever, difficulty swallowing. These seem like your normal symptoms of a sore throat. You have white patches on the tonsils. So which of the following could the organism be? This would be strep pyogenes, which is A. It is gram-positive in chains, cocci. Okay. Also known as group A strep. Okay. Next, which test is most commonly used to detect corynebacterium diphtheria? I just explained this, so D, ELIC test. B here is the satellite test. I think it came earlier and I said camp test. Sorry, it's not camp. This is the satellite test for Haemophilus influenza. And then this would be the rapid antigen test. And then I think this is niacin test. But yeah, ELIC test for corynebacterium diphtheria. Now, for influenza, this is honestly not too important. It's not really relevant to OSPE that much. I don't think I've seen any questions, but I just wanted to put it here for completion's sake and for your reference. Know what type of virus it is: negative, single-stranded, segmented, and enveloped. Each part of this phrase is important. Know it and memorize it. It might come in a question. The structure of it, the important thing is NS1. This is what confers the virulence of the virus. What's it called? NA and HA. These are the ones that basically subtype the Haemophilus influenza, type A. And what else? Antigenic shift and drift. Important to know the concepts, what they are. Antigenic shift includes the virus goes through genetic reassortment, which is it changes it into a completely new virus. And this is the reason for pandemics. So antigenic shift is much more serious. Antigenic drift is just a small change in the RNA structure that changes. The virus is still the same virus, it just changed its configuration a little bit. And this causes seasonal infections, so it's less severe. And this is more common in influenza B. So influenza B is what we get vaccines for every year, or if you get your seasonal flu shots. Influenza A is responsible for pandemics. Now, the uncoding process of influenza, this is a past question that I saw that I thought was important to mention, is caused by the low pH and M2 protein, this protein, the ion channel. So remember this. Okay. For the features, again, not really going to go through this. Diagnosis, we use ELISA, rapid ELISA, PCR, all of this. Prevention, there is a vaccine. You have different types of configurations of the vaccine. It's either killed, egg-based, or live attenuated, recombinant, cell culture-based, different types of vaccines. So go over these. Hopefully for your MCQs, they'll help you, but not too important for OSPE, as I said. All right, so next we have stages of pneumonia, or pneumonia in general. We're going to talk about it. So the stages are very important to know the days exactly, what happens in them, how they look, all of that. So in the first 2 days, you have congestion. This is all caused by the initial bacterial infection causing a lot of exudate release. So you get congestion in the first 2 days, and then you get red blood cells coming in along with white blood cells and more exudate, fibrin. This causes red hepatization, and then you get gray hepatization where the macrophages start to die, and then you get resolution where they get removed, the dead macrophages. Now, why is it called hepatization? Because basically it starts to look like a liver, and the lung no longer becomes like soft and how a lung usually is. It starts to resemble a liver more. Okay, so first question, which stage of pneumonia is this, and what are the findings that you can see? So this is the first 2 days where you have congestion / early red hepatization. The first few days kind of blend into each other. So here you see a lot of neutrophils in the alveoli, and the capillaries are very congested. So it kind of has both. You see red blood cells and stuff, and then you also see the neutrophils coming in at the site of the infection, causing congestion. But this is the first 2 days. Next. This is gray hepatization, or days 5 to 7 of pneumonia. And what are the findings that you can see? This is when the cells start dying off, basically, which is why it's gray. So you have disintegration of red blood cells and fibrinosuppurative exudate, which gives it that color. This is organization, resolution. This is when you start getting fibrosis. Actually, it's not the same as resolution. This is organization when you start having fibrosis, which is everywhere here. These are all fibrosis. Okay. This picture is diffuse patchy consolidation. I saw it in past, but I wasn't sure if you guys took it. But you can tell that it's diffuse. It's all over the lung because it's all around the bronchioles, and you can see consolidation. I thought I'd just put it here for completion's sake. Okay, what is this? It says it, but very important picture to recognize. Okay, so this is an abscess. How can you tell it's an abscess? Because it has what is called an air fluid level. And this is caused by the pus, basically. It goes down, and obviously in the lung you have air. So you're going to have fluid in the bottom, air at the top. It's going to make a very distinctive line called an air fluid level. And this is called a lung abscess. And most commonly caused by Staph aureus. They very commonly cause abscesses all around the body, not just the lungs. But for this case specifically, obviously the lungs. Strep pyogenes, Klebsiella, and Pseudomonas can all cause lung abscesses. These are more images that have lung abscesses. I don't think they were from your lectures, but they were in past, so I wanted to include everything. Here, what are all of these? This is one thing, and then this is another, and then this is another. Those are 3 diagnoses. Okay, so here we have lobar pneumonia. Lobar pneumonia is confined to a specific lobe. You can just see an area of consolidation. So here you have lobar pneumonia, here you have lobar pneumonia, here and here. Again, I put every picture that I found. Bronchopneumonia is more of like patchy. So you see patches around the lungs. And then interstitial is just everywhere. So it's diffuse, basically. Bronchopneumonia is more patchy. Lobar pneumonia is localized. And then here again, this is pneumonia again, lobar consolidation. And then here you have what is called an air bronchogram, which is basically streaks of air. Like, it's when you can see air on an imaging modality, like clearly. This is called an air bronchogram, because usually air is just black. But if it's surrounded by white, which is the consolidation in this case, you can start seeing the air as streaks. So the black streaks is an air bronchogram, and this can be seen in pneumonia. Again, what is this? Pneumonia again. Okay, case time. So you have 55-year-old diabetic female smoker, signs and symptoms of pneumonia for 1 week. Which stage of the inflammatory process can be seen? So this is the gray hepatization phase, and they said 1 week, which is like 5 to 7 days. So sometimes they might say the exact days, sometimes they might say a week. You'll have to like do your context clues. And so this is gray hepatization. What microorganisms are most likely to cause infection in this patient? So what are the most common causes of pneumonia or community-acquired pneumonia is basically the question. So you have strep pneumo, Haemophilus, Moraxilla catarrhalis, and Staph aureus. Memorize these very well. Okay, here we have a 40-year-old diabetic female smoker. History of pneumonia. Sputum shows what? Gram-negative coccobacilli. And the organism grows on chocolate agar with factor 5 and 10. These are all very important features. So based on all of this, what do you think the organism is? This is Haemophilus influenza. Now, I don't think this is in any of your lectures, but it was in the CPC, and you know what Haemophilus influenza is, obviously. So I just wrote a little summary of the main findings or main features of Haemophilus influenza. So firstly, it is gram-negative, and it is a coccobacilli. It requires special growth factors, which are factor 10, hemin, and factor 5, or NAD. They grow on chocolate agar, and this is where you see the satellite phenomenon, which is basically Staph aureus. It provides hemin, or factor 10. So when you grow Haemophilus influenza on blood agar with Staph aureus, it's able to grow because Staph aureus provides hemin. These are not from your lecture, but They're all based on the findings in the CPC case. Okay, describe the microscopic appearance of this patient's lung. So describe both of them. Here you have alveoli, exudate, neutrophils, sorry. And then here you have the organization phase. Okay. Explain why patients with splenic dysfunction are specifically vulnerable to such infections. So, you know, the function of the spleen is basically to kill off or eat bacteria. In the case of encapsulated bacteria, their main virulence factor is that this capsule is resistant to the immune system. It walls off the immune system. So it's able to evade our immune system. So in the case of asplenic patients or sickle cell patients, they are especially vulnerable to these infections. Okay. Now, what is the diagnosis here? You have rusty sputum, you have these gram stains, you have this test, and alpha hemolysis. What is all of this? Strep pneumo. The most common cause of community-acquired pneumonia, and it is gram-positive diplococci. And rusty sputum, very, very characteristic for strep pneumo. It will be described that way. And then optician test, is it optician sensitive or resistant? It is optician sensitive, which is why you have this area of inhibition around the optician disc. And it shows alpha hemolysis, so it's green. Alpha hemolysis is more green because it's partial hemolysis. Beta hemolysis is complete hemolysis, so you'll see like whitish color or grayish. And then gamma hemolysis is no hemolysis. Okay. Here, what is the diagnosis? You have red currant jelly sputum. Very, very, very characteristic phrase. Oh, it actually says it here. Oopsies, guys. Pretend you didn't see that. Okay, so what is this? Klebsiella pneumonia. Klebsiella pneumonia is very common in which demographic? Alcoholics, yes. Why? Because it's one of the causes of aspiration pneumonia, and you can aspire things when you are unconscious or not in your right mind, like in alcoholism. So alcoholics, Klebsiella pneumonia. The sputum is described as red currant jelly, and they are gram-negative bacilli. This is how they look, and this is how it looks on agar. Okay. Next, what is this? This is pneumocystis jirovecii. Now, what is significant about this? Which demographic, again, is it most seen in? This is an AIDS-defining illness, so it's very commonly seen in people with HIV or low CD4 counts. That's pretty much all you need to know. Now, what is this? Pseudomonas, green, you automatically think of Pseudomonas. And it is oxidase positive, differentiating it from Shigella. Remember this. Which of the following is used for sputum collection? Guys, this is A. I actually got this wrong in our OSPE, and I'm traumatized from it because it's so easy, but I was overthinking it, and I completely forgot this is what the sputum collection tube looks like. So the sputum collection one is the one that's like bulkier and smaller. Okay. You'll probably get asked about this too, so please memorize it. Okay, a 48-year-old presents with high-grade fever. So you honestly don't need any of this, actually, at all. You can see it from the image. What test can better assist in distinguishing this organism? So this is what Pseudomonas. We said Pseudomonas was oxidase positive, so you can use the oxidase test to test for Pseudomonas. You can mostly solve this using process of elimination, because why would you need any of these? Oxidase test makes the most sense for Pseudomonas. Patient presented with dyspnea, cough, pleuritic pain, sputum production, suspected strep pneumo. Which result would support this case? So what are all of these showing? These are showing different phases of hemolysis. So we said strep pneumo is alpha or beta hemolysis, alpha hemolysis. Alpha hemolysis shows up as what? Greenish. So it's B. This would be alpha hemolysis. This would be gamma hemolysis. Okay, next. We have a case of a 7-year-old boy. Again, important. Age is important here. Right ear pain, erythematous posterior oropharynx, bulging tympanic membrane. So he has features of otitis media as well. So what could be the most probable cause? Strep pneumo. Strep pneumo causes pneumonia, causes otitis media, many different things. And these fevers of fever, sore throat, congestion. So which one is this? It would be B. B is, we said it's gram-positive diplococcide. Okay, next. Which of the following shows green colonies on nutrient agar? He said, you see green, you automatically think Pseudomonas. So this is C. A catalase negative organism, frequently causative agent for pneumonia. So what are we thinking? We're thinking of strep pneumo. Which of the following tests would distinguish it? We mentioned optician test. So B. Optician sensitive would be strep pneumo. Optician resistant, strep viridans. This is catalase, CAMP test. I didn't really use it anywhere here, but it's come up a lot in the options. Okay, now for COVID, again, it's one of the causes, but of pneumonia, but I'm not going to go into it too much because it's not really part of your OSPE objectives. However, memorize this very well. It is enveloped, it's positive sense, single-stranded RNA. And it has these structural proteins, the spike proteins. These are what allows the virus to enter the cell, and it does this by binding to ACE2, or like angiotensin converting enzyme 2. So yeah, this is what enters the cell. You have the nucleoprotein of the genome. This one is responsible for inhibiting the host cell defenses and also promoting RNA replication. I think that's the main things you need to know about COVID. Again, these are different things that I added for the sake of completion, how to diagnose it, and vaccines. You have different types of vaccines: viral vector, RNA, whole virus, protein subunit. Again, I'm not going to go too much into it. I just wanted to summarize what was in the lecture. And this is a summary table from first aid for the types of pneumonia, the causes, and what is like special about them. So, for example, alcohol overuse, you have Klebsiella, or things that cause aspiration, anaerobes. Aspiration by anaerobes, cystic fibrosis. Oh, I forgot to mention this before. Pseudomonas is associated with cystic fibrosis. Maybe I didn't mention it, I don't know, but cystic fibrosis, Pseudomonas. For immunocompromised, we mentioned pneumocystis jirovecii with associated with HIV. And post-viral, Staph aureus is very common. COPD in Haemophilus influenza, very common. So yeah, don't focus on everything here, just the important things, and if you need it. Okay. Okay, so now I have a case. A smear is prepared from the sputum of a patient who presented to the pulmonology clinic with a history of fever, hemoptysis, which is associated with drenching night sweat, and weight loss. 3 early morning sputum specimens were sent to the microbiology laboratory for evaluation. So the symptoms that I have in red are the alarming symptoms that you see, and these initially make you think of something like malignancy. They also make you think of something else, but we're going to get into that and see what it is. So in order to properly diagnose it, you sent sputum specimens. And for this, the same patient. Which of the following should be ordered? So the answer is A, which is Lowenstein-Jensen medium, which is specifically used to visualize TB. Oh, I just spoiled it. I wasn't supposed to say that, but it's okay. You guys probably knew it. Okay, now based on this, the findings of the patient and all of everything here, what is your diagnosis? So this is secondary TB. Now, why did we say secondary and not primary? Primary TB usually does not have symptoms that are that severe. This is mostly seen in secondary TB. And also, secondary TB tends to favor the upper lobes of the lung. As you can see in this X-ray image, they are mostly in the upper lobes because this is where oxygen is highest. Whereas primary TB, this is your initial ingestion of the organism. So the first place it goes to is like the middle to lower lungs near the hilum. And that's where you'll have your GON complex or focus, all of that. And that'll be in primary TB. Secondary TB, however, this is clearly secondary TB. And you see, what do you see in the gross images? You see caseations, you see cavitations, and in the histology images, you see caseating granulomas. This is a non-caseating granuloma. Can this be seen in TB? Yes, it can be seen in the earlier stages of TB. However, as the disease progresses, it turns into caseating granulomas. Now, what caseating means is basically it has a central area of necrosis, which is what can be seen here. Now, a granuloma is basically a giant cell. You guys know that, right? And they are basically groups of macrophages that group together, form epithelioid cells, and then giant cells, Langhans giant cells in the case of TB. What is the mechanism involved in the formation of these? Basically, how are they formed? Through a cell-mediated type 4 hypersensitivity reaction, also known as a delayed hypersensitivity reaction. So just to summarize quickly how TB happens, as I said, you basically take it and it goes in your body, and then macrophages ingest it. They present it to T helper 1 cells. T helper 1 cells activate cytokines, specifically interferon gamma. Very important. Interferon gamma starts recruiting more macrophages, and then macrophages start engulfing the bacteria, basically. And there starts to be a lot of inflammation. The groups of macrophages all together, they start fusing together and form epithelioid cells, and then Langhans giant cells. And then as the disease progresses, these macrophages, some of them start dying off, and some of them start being recruited even more. So these, the necrotic macrophages form the central area of necrosis in a caseating granuloma. And that, in a nutshell, is TB. Okay, so what is this? This is miliary TB or disseminated TB. So TB can spread through the lymphatics, and it can affect many different parts of the body, one of them being the spleen. Okay, patient presented with a history of weakness. Okay, they have night sweats, weight loss, and the physician is suspecting Mycobacterium tuberculosis. What would support this suspicion of Mycobacterium tuberculosis? Which finding specifically? B. B is the acid-fast or Ziehl-Neelsen stain of TB. And anyone suspected of TB with these symptoms, based on clinical evaluation and history, if you suspect TB, you have to take a sputum sample, 3 consecutive sputum samples to be specific, and they have to be collected in an 8 to 24-hour interval, with at least 1 being an early morning specimen. So these are the criteria for collecting a TB sputum sample. And this is the Ziehl-Neelsen stain, Ziehl-Neelsen, or acid-fast. Now, why do you need to use an acid-fast stain? Because TB does not have a cell wall, as we know, or it does have a cell wall. The cell wall is made up of mycolic acids or long-chain fatty acids. And these fatty acids do not take up the gram stain. So you need to do something called an acid-fast stain. You basically stain it with something else and then counter stain it. And this way, this is the only way that you'll be able to see it. So the main thing you should take away from this is the primary stain is the carboyl fuchsin stain. And then you counter stain it after rinsing, decolorizing, rinsing. You counter stain it with methylene blue or malachite green. This is the methylene blue. This is what gives it the color. Okay? And then this is how it's performed. Now, there's other diagnostic medias. Not sure if they're too important for you. I don't think they are, honestly, and they're from your lectures mainly. You have solid and liquid media. Liquid media is more sensitive than solid media and faster. Solid media is like Lewinstein-Jensen, which is used for TB. I think you all remember that from POD. And this is egg-based. Middlebrook, it can either be solid or liquid. There's two types. And yeah, these are just different diagnostic methods. Now, there are different types of Mycobacterium species, not only Mycobacterium tuberculosis. Not sure of the importance of these either, but they can be differentiated based on the speed of their growth and their ability to produce a pigment. So whether they're chromogens or non-chromogens. So you have 3 different species that you should know or from your lab. Mycobacterium tuberculosis does not produce a pigment, so it's non-chromogen. It is, and it's a slow grower. Mycobacterium avium, by the way, just so you know. So these tubes, the one on the left has been exposed to light. The one on the right has not been exposed to light. So, or no, wait, the opposite. This has been exposed to light. This is not exposed to light. So if when exposed to light, it produces a pigment, this is a chromogen. It's pigment forming or pigment producing mycobacteria. Mycobacterium tuberculosis, as you can see, whether it's in the light or not, it did not produce a pigment, so it's non-chromogenic. Mycobacterium avium, same thing, did not produce pigment. However, this is fast growing. So TB was, Mycobacterium tuberculosis was slow growing. Avium is fast growing. Mycobacterium kansai, or whatever that is, this one is photochromogenic, so it does produce a pigment when exposed to the light. And it is also fast growing. So, main features that you should know about TB is it's a slow grower, it is non-pigmented, it is niacin positive, which is vitamin B3, so it has niacin. It also has nitrate reductase, the enzyme, which converts nitrate to nitrite, and it is urease positive. So all of these images describe this. Non-chromogenic, as I showed you earlier. Niacin positive, this would be positive, this would be negative. Nitrate reductase, positive. The darker one would be nitrate reductase, positive. Urease positive would be the pink one. So this is urease positive. And also important to know that it has a live attenuated vaccine, which is BCG. Now, latent TB, what I want you to know is that you can quantify it by this quantiferon TB, the interferon release assay. This came in a past question, and I just wanted to include it for completion's sake. Now, in order to screen or diagnose, you do the Manteau test, or you use the PPD, which is the purified protein derivative, and you basically inject it into the skin, and you assess for induration. Induration is basically when there's like a bleb above the skin level, and the amount of induration depends on, or like how we interpret this induration is based on the patient's immune system, how immunocompetent they are. So what is expected in a healthy patient whenever you inject PPD is the immune system will form a reaction against it because it's never seen TB before. It's something completely new to their body. However, if someone has already been exposed to TB, then or has a weaker immune system, they won't be able to form this big of a reaction. So if the PPD, so basically there's a threshold. For healthy individuals, it's 15. So if you have an induration of 15 or greater, then this is a positive PPD or Mantoux test. Now, it can be positive either if you have had TB before or if you've had the BCG vaccine, because as we said, it's live attenuated. So it would form a reaction. Now, if it's greater, memorize these numbers. If it's greater than 15 in a healthy patient, this would be positive TB. If it's greater than 10 for people who have been in endemic areas of TB, for example, this would be positive. And for immunocompromised patients like HIV or had recent contact with TB, greater than 5 would be enough to diagnose it as a positive PPD. Why? Because their immune systems are weak anyway, so we can't expect it to form that big of a reaction. So yeah, memorize these numbers. This got asked in past before. HIV positive and recent contact would be the criteria for having positive, having an induration of 5 or greater. Okay, now moving on to cancers. So here we have a 67-year-old smoker. Oops, sorry. Was there red? Yeah. Okay. Smoker presented with multifocal bone pain for 5 months. Patient also has multiple enlarged non-tender lymph nodes. A CT scan shows central lung mass. Now, when we looked at the serum calcium, it was elevated. Phosphorus was low. Immediately, what does this tell us? You can see the pictures too, but right now we know the diagnosis just based on this information. Bone pain, increased calcium. This tells us there is some kind of perineoplastic syndrome that may be releasing calcium in the form of PTH-related peptide. And also there was a mass, there's enlarged lymph nodes. So this is all very cancerous. Now, what is the most likely diagnosis? Most likely it is a squamous cell carcinoma. Okay? Now, describe the gross findings. So the gross findings here, what can you see? Here you can see the there's an infiltrating mass in the lower lobe, and the lung parenchyma is blocked. Okay. List 2 histological criteria for your diagnosis. Now, squamous cell carcinoma has very specific findings that you can see in all over the body. Any place where you have a squamous cell carcinoma, you're going to see these same findings. So what are they? You have keratin pearls, and you have pink cytoplasm with distinct cell borders and prominent nucleoli. So remember these features for squamous cell carcinoma. Now, how would the laboratory findings explain the patient's bone pain? Now, I explained this to you earlier, how if you have a high serum calcium and a low phosphorus, this is basically the action of PTH. Now, PTH, why would it be increased here? As a perineoplastic syndrome, where the lung cancer produces PTH-related protein. It can also be from metastasis to the bones that causes bone pain. Okay, now, what is the diagnosis here? Again, this is a squamous cell carcinoma. So this is a squamous cell carcinoma, as we said, and in the X-ray image, you can see that the trachea is shifting. This tells you that there's a mass because the fibrosis basically, in the mass, it basically pulls the trachea towards the side of the mass. And this is a gross image of squamous cell carcinoma. Okay, now what can be seen here? Again, squamous cell carcinoma, you have keratin pearls and desmosomes. These are, again, characteristic of squamous cell carcinoma. Please recognize these images. Okay, what are these stages of squamous cell carcinoma? You can get any of these stages in the exam. So it starts off with the normal epithelium of the respiratory tract just starting to be hyperplastic. So you have goblet cell hyperplasia in the beginning. And then what is B? You have basal cell hyperplasia. So this is when all of these, the dark colored cells, they should all only be on the base of the epithelium, but it's all over. So here we can say this is basal cell hyperplasia. And then these columnar cells, you can see they're starting to become squamous. So we have squamous cell metaplasia, going from one type of cell to another. Here, you start having these cells everywhere and they look dysplastic. Their NC ratio is off. They have all of the dysplastic features. So this is dysplasia. And then here, it started to form a carcinoma. However, it's in situ. It did not invade the basement membrane yet. Here, the last one is when you have an invasive squamous cell carcinoma. It's invading the basement membrane. Okay, so know all of these very well. All of the stages. Okay, next we have a 55-year-old female presents with persistent cough, fatigue, and unintentional weight loss for 1 month. Again, constitutional symptoms making you think of cancer. Radiology shows a peripheral lung mass. This is a key word, peripheral lung mass. And then they showed you this image. This image looks these look like glands, right? So what is the diagnosis? Adenocarcinoma, adeno for glands. And then risk factors for developing adenocarcinoma, smoking, exposure to radon gas, family history, and asbestos exposure. Although you will see it in non-smokers, and it's commonly described that way in questions. It's more common in females and non-smokers. Now, what is the marker for adenocarcinoma? TTF1 or the thyroid something 1. I think I have it written later. Okay. Okay, now diagnosis. Again, adenocarcinoma of the lung. So we said we have a peripheral lung mass, and again, the trachea is shifting to the right, and it's peripheral. It's shifting towards the area of the mass. Okay. Identify each stage of the progression of this disease. So again, these are all adenocarcinoma. However, different stages of it. Okay. So first you have atypical adenomatous hyperplasia. This is the precursor of a adenocarcinoma. Okay. And then you have bronchiolo-alveolar carcinoma in situ, or BAC. And then you have invasive adenocarcinoma. This one is TTF1 positive. Okay. This is the marker for it. Okay. Know how to see, how to identify all these images. Okay, now identify. Okay. Again, these are types of adenocarcinoma. You have glandular and you have mucinous. Mucinous has red on PAS stain. And glandular has all glands. Mucinous forms mucin. Okay. Next. What are these two images? Okay, so you have bronchoalveolar carcinoma. It can be either mucinous or non-mucinous. Mucinous meaning it has mucus, or it forms mucin. Okay. Okay, now I have a 60-year-old man, smoker for 20 years, 6-month history of worsening cough and recent weight loss. Chest x-ray shows a hilar mass and hilar lymphadenopathy. So hilar mass and smoker, cough, weight loss, and serum cortisol is elevated. Now, they don't give you these investigations for nothing. They want you to actually think about what could be causing this. So what cancer or malignancy do you know that could cause increased cortisol? What is the case of increased cortisol? Cushing's. What causes Cushing's, or what paraneoplastic syndrome? What cancer is associated with a paraneoplastic syndrome of Cushing's? That would be small cell carcinoma. Now, small cell carcinoma also can be You can also identify it from the cytology and the histology. They all look very monotonous, and that's how it's usually described. Okay, why does he have increased cortisol? We just described it. So it's Cushing's from a paraneoplastic syndrome. The natural history of this disease. So prognosis-wise, it's a very poor prognosis. It's the one with the worst prognosis out of all is the small cell carcinoma. Okay. All right. Now again, identify. This here is a small cell carcinoma. Here you have a large cell carcinoma. 1 second, I need to charge my laptop. Okay, so this is a small cell carcinoma and this is a large cell carcinoma. Question: which markers are associated with small cell carcinoma? Those would be neuroendocrine markers. It's neuroendocrine in origin. So you have synaptophysin, you have CD56, you have chromogranin A. All of these are markers of small cell carcinoma. Now, as I said, it has a very poor prognosis. It has also paraneoplastic syndromes associated with it, including SIADH, Cushing's disease, as we said, and Lambert-Eaton. Okay, these are, and yeah, as I said, they're very monotonous in appearance. They look the same. And large cell, you have these anaplastic cells, and just recognize the image. Okay, now what is this here? Okay, here you have a tumor at the hilum of the lung, which is a Pancoast tumor. Pancoast tumor refers to any tumor at the hilum of the lung, or not hilum, sorry, the apex of the lung, and it can compress the sympathetic trunk, leading to symptoms of Horner's syndrome, such as anhidrosis, ptosis, meiosis. So this is just something to note about Pancoast tumors. Next, what is this? This is carcinoid tumor. Now, carcinoid tumor is, what markers does it have? This also is neuroendocrine in origin, so it has the same markers. Synaptophysin, chromogranin A, CD56, and this has a very good prognosis. The best prognosis is carcinoid tumor. Adenocarcinoma also doesn't have too bad of a prognosis, but this is the best prognosis. Worst prognosis is in small cell. Also, I forgot to mention adenocarcinoma is associated with, and the mutation associated with it is EGFR. Make sure you know that because I saw that in a lot of questions. Okay. This is another picture of carcinoid tumor from past. Okay, so next question. This is a hamartoma. So hamartoma is just tissue in the wrong place. It's not malignant. It's not, it's very benign. And here you can see cartilage, basically, which is, as I said, it's tissue growing in the wrong place. So this is a hamartoma. It's very well defined. It does not look scary or malignant at all. And on CT, it has a very specific appearance. Do you know what it's called? This is a popcorn lesion. Okay, next. Identify this. This is a malignant mesothelioma. So grossly, a malignant mesothelioma, you see gelatinous and like soft tissues in the lung and in like surrounding the lung. And important about this is, what is it associated with, or what is a risk factor for malignant mesothelioma? Hopefully you guys said asbestos exposure. Okay. Next. This is diffuse malignant mesothelioma. And you have two different types. The epithelioid type, or epithelial, this one, which is more common, or the sarcomatous type. know how to identify these. Okay. Next, identify the picture representing squamous cell carcinoma. So these are all one of the stages, but which one is invasive squamous cell carcinoma? A. Okay. This is dysplasia. This is goblet cell hyperplasia. This is in situ. Okay. Which of the following histopathological images is associated with TTF1 positive? You mentioned this. See, adenocarcinoma is associated with TTF1 positive. Remember this. Okay. Now, we're mostly done. Just a few extra radiology images. So this, you can see consolidation and where the arrow is pointing. Here, what can you see? This is metastasis. Okay, it's just, you can see different, it's like widespread around the lung. This is metastasis. And that is it for cancers. Honestly, just look at the pictures very well. Remember all of the features of each cancer, the markers, if any, the neuroendocrine ones for carcinoid and small cell, the TTF1 for adenocarcinoma. Remember the paraneoplastic syndromes, very, very important. Remember just how they all look like. Honestly, the questions won't be difficult, inshallah. And you'll be asked a lot about this even in MCQs. So look out for all of the hints and keywords and everything that we talked about. And look at as many pictures as you can. Go over all the pictures before your exam to just recall all of them easily, inshallah. And inshallah, you'll have the best exam. And best of luck. Ghedaa will take it from here. And thank you very much.
Ending this PAL will be the miscellaneous section. And after this, we're going to be done. Okay? So it's going to be very quick, very easy. It's going to include your microlabs, some OSPE past questions, and some miscellaneous stuff, essentially. Okay? So hang on tight. Okay. We're going to start with micro. So in blood collection, the main thing that you need to keep in mind is the timing. Okay? You need to start collecting blood or collecting the samples before antibiotics. And if you're doing it after antibiotics, make sure that you're waiting at least until the course of the antibiotic is over so that you can take an accurate sample of the blood and it's going to be representative of the infection that the person has. Okay? Now, disinfection and specimen collection. When you are collecting blood samples, they have to be from different venipuncture sites. Okay, this is distinguished between true bacteremia and contamination. If the same organism grows in cultures that you collected samples from different sites of the body of different venipuncture sites, this will show that this is not a contamination and this is an actual bacteremia. It's a real infection. Okay, because it's from different venipuncture sites, this means it's more likely to be associated with the infection itself and less likely to be associated with a contamination issue. Okay. Now, collection, it has to be from the upper limb, not the lower limb, and not from an existing already there existing line. You have to attach the venipuncture kit solitarily and do it. Okay. Now, you need to transport promptly after collection within 2 hours. And make sure not to refrigerate. Do not refrigerate, okay? Now, number of sets is 2 to 3 sets. In each set, there will be 1 anaerobic bottle and 1 aerobic bottle, okay? And as I said, each from a different venipuncture site. So each set is from a different venipuncture site, okay? This, as I said, will help us in identifying if this is a real bacteremia or just contamination, Okay. In case of repeating the sets, you have to wait 2 to 5 days approximately, and yeah, that's it. This is what the sets look like. As I said, there's an anaerobic bottle and an aerobic bottle, two separate colors. This is a question that's going to come in your OSPE, okay? But please choose a picture that has two colors, not one. And two bottles at the same time, okay? So two bottles, two different colors. One aerobic, one anaerobic. Come on. Now for sample collection. As you guys know from Pro, you have to clean and defat the site with 70% alcohol for 30 seconds, okay? After that, you apply 70% isopropyl alcohol and in 2% chlorhexidine, okay? Or use 10% iodine from the center to the outside until the skin is sufficiently saturated, okay? And let it sit for about 30 seconds, okay? Afterwards, you get your venipuncture kit and you get the bottles that we talked about. You mark to where you want or the level will be, okay? Mark the desired level and clean it with alcohol before starting. And then use your venipuncture kit, this one, okay? You attach it to the bottle and then you insert the needle and you collect the blood and you send it to the lab within 2 hours, okay? Now, keep in mind two things. If the vial has a TCO2 sensor, that means it's collecting carbon dioxide samples from bacteria, okay? And if the time to positivity is more than 48 hours, it's probably a true infection, okay? That's it. Now, until when you get the opportunity for a specimen collection, there are multiple specimen collection methods for different types of organisms, okay? So you have strep pneumo, and the main collection method is by sputum. Keep that in mind, okay? How do we do that? We start by preparing the container. This is what the container looks like, okay? Please do not select another picture. This is the picture they want. It's the one with the flat tip, okay? First, you prepare the container and you make sure it's labeled. You make sure you have gloves, you have tissues, and you have water, okay? You prep the patient. You make sure that the nose is blown so the nasopharynx is clear. You make sure that they brush their teeth without toothpaste, and this is to reduce oral bacteria, and then you ask them to cough deeply in order to get the sputum out, okay? And then you get the sputum out and then spit it into the container essentially, okay? If they can't cough and they can't spit the sputum into the container, use a nebulizer or chest physiotherapy in order to help thickened secretions in the lung, okay? Then when you're done, seal the containers, make sure your gloves are on to reduce contamination, and fill out the label. Transport immediately, and in case of a delay, refrigerate it. This is different, this is not blood sample, okay? In case of a delay, refrigerate it. It's okay for TB and not for pneumonia, okay? So not in this case. It's okay to refrigerate a sample from a TB patient, not from a strep pneumonia infected patient, okay? Now, we have collection methods for the other microbes. We have for CMV, bronchoalveolar lavage, pneumocystitis, we have lung biopsy. For RSV, we do nasal washing, okay? The two other collection methods that we use is deep tracheal aspirate and pleural fluid. For deep tracheal aspirate, we usually use it for infections with Staph aureus, and pleural fluid is just for if there's pleural effusion or whatever we aspirate it. You don't need to go into the details of how these stuff occur. Just memorize them. Now, diagnostic procedures. There are multiple diagnostic procedures, and some of them are specific for specific type of microbes. So for microscopy, you usually use gram stain for a lot of the bacteria. However, in case of TB, we use xanthan stain. For serology, it can be used for mycoplasma pneumonia, for strep pneumo, for Legionella. NAT can be used for influenza, RSV, and coronavirus. And then skin tests. Skin tests can be used for TB, the tuberculin test, and some fungi types. There are also diagnostic macroscopy, culture, and other types. Okay. Now, using gram staining for proper sputum specimen, after you get the sputum, you want to look at it under a microscope using gram stain. Okay. Now, if you have an actual infection, the main two things that you're going to see are many PMNs, which indicate inflammation, and predominant single morphotype of bacteria. Okay, so it's only going to be one type of bacteria that's going to be clearly predominant in the microscope, gram stain. Okay, what to reject in that case? On the other hand, what to reject? If there are too many squamous epithelial cells, that means when there's contamination, and if there is candida. Okay. Now, keep in mind that not all organisms are visible under a gram stain, so they're going to need other modalities, say mycoplasma and chlamydia. And in immunocompromised patients, the number of PMNs might be low. So this is not very indicative, but it usually indicates an actual infection. Just keep in mind that in immunocompromised patients, the number of PMNs will be low, despite the fact that they have an active infection. But it shouldn't exclude it. Okay. Now, when we're looking at two micrographs, these two, okay, which one of them would have an active infection, and which one of them would be rejected? Exactly. So this one would be rejected, and this one would be approved. Why? Because you can see in this one, there is one clear morphotype of bacteria, okay, and there are a lot of neutrophils, clearly seen, okay. But here, you can tell it's contaminated. You can tell there's epithelial squamous cells. Too many things, okay. This is why it gets rejected. Now we have Kirby-Brewer and disc diffusion. Another a way for antibiotic susceptibility testing. Okay. Now, in Kirby-Brewer is a qualitative. It's a qualitative test, and in e-test, it's both a qualitative and a quantitative test. Okay. Now, this is what Kirby-Brewer looks like. The plate, the agar, will be either a nutrient agar or a blood agar. It doesn't matter. It's usually a nutrient agar. But don't focus on that detail too much. Keep in mind that more than one antibiotic can be tested at the same time. And just because there is a bigger diffusion doesn't mean the antibiotic is better. We have to look at the guidelines and sort of measure the distances between each zone. You don't have to know any of this. Just memorize this picture and know that this is Kirby-Brewer. That's it. E-test is more likely to come in your exam than Kirby-Brewer. Yeah. As I said, it's qualitative and quantitative, and it determines the minimum inhibitory concentration. What a minimum inhibitory concentration is essentially the amount of the lowest amount of antimicrobial that visibly inhibits bacterial growth. It doesn't kill it, just inhibits bacterial growth. Okay. And how to do it is that we essentially have a stick, a sheet of paper, filter paper, dipped in antimicrobial agent, and we lay it down on the agar, and we look at the zone of inhibition. Okay, if there is a zone of inhibition, that means it's bacteriostatic. If there isn't, خلاص. Okay. Last test for antibiotic susceptibility testing is MIC and MBC. We talked about MIC, and as I said, it's the minimum inhibitory concentration, and it shows bacteriostatic effect. MBC. Sorry, this is wrong. MBC is minimum bactericidal concentration, and this shows bactericidal effect. Essentially, what both of them are, as I said before, MIC is the minimum or the lowest concentration of an antimicrobial that is used to visibly inhibit the growth of a bacteria. Okay, and it can be either through a broth. It can be through two modalities, either broth or agar. Okay, so once we do the broth for MIC, we put a specific amount of a microbe into the broth, okay, for all of them, okay, and then we have a specific concentration of the drug, okay. So in this one is 0, in this one 0.5, and this one is 0.25, this one is 0.5, this one is 1, 2, 4, 8, okay, and then we determine the MIC, okay. Once that is determined, we determine that 2 micrograms per milliliter is what is the MIC. Okay, at this concentration of the drug, this is the MIC. We take this broth and we subculture it into drug-free agar, and we look for the MBC. What the MBC is? The minimum bactericidal concentration. So it's the lowest concentration of a microbial agent that kills 99% of the initial bacteria population. I hope that makes sense. And there's more explanation in the notes section. However, if you have any questions, feel free to ask. It's a little bit confusing, but you don't have to go into too much detail. Just understand these two concepts. One is bacteriostatic, one is bactericidal. How this dilution thing goes on, that's it. Okay? Now, cardiac enzymes is going to be a question in your OSPE. Okay? There are 3 main lines over here. There's the red line, there's the troponin. There's the yellow line and there's the green line. Okay? So the red line would be myoglobin. It's the first one to spike. However, because it's the first one to spike, myoglobin is found in muscles in general. So it's not very specific when there's an MI. Okay? The yellow one is troponin. And troponin is more specific, and this is why we usually focus on it more than myoglobin. Okay? And lastly, we have CKMB in the green. Okay? That's it. Just memorize this picture. It's either this one or another form of it that will come in your final. But essentially, it's the same graph. Okay? So memorize it. Okay? So, which X-ray is PA? Very easy. Posterior anterior is A. Okay? Diagnosis for this chest X-ray, pleural effusion. Why is it pleural effusion? Because fluid does not show on X-ray. And if there is any darkness, it's usually air. Okay? You can't see any air over here, no darkness. Okay, that means pleural effusion. Okay? There is fluid in the lungs. Okay, so I'm gonna read this. There's a 63-year-old man presenting with worsening dyspnea. He started breathing heavily a few years ago, but now he has difficulty breathing even with mild physical activity. His physician orders chest X-rays and PFTs. X-rays are shown, and his VF1 is 70% of predicted, and his FVC is 76% of which is typical of interstitial lung diseases. Which of the following chest X-rays shows the most likely diagnosis? We saw this picture before. It's C. Okay, it's the exact same picture we saw before. So the web-like appearance. Okay. Which of the following images shows pleural effusion? Again, it's B. It's not A because this picture shows pneumothorax or tension pneumothorax, to be more specific. This lung is darker than this one. How does it make sense for it to have pleural effusion? You know, and as we know, fluid accumulates because it has a higher density. It accumulates at the bottom. Okay, so moving on to ABG interpretation. Now I'm going to give you some time. You can use this equation to help guide you through the answer, but it's very simple. Okay. Now, under pH, we're gonna go through each of them and find the answer through that. Okay, it's gonna be very easy. Okay? So pH, the normal pH in ABGs or in the human body is 7.35 to 7.45. Okay, so from that we know that this is alkalotic because it's higher than 7.45. Under CO2, we have over here is 29, which is lower than the normal, which is 35 to 45. Okay, it's lower than 35, so it's respiratory alkalosis because it's CO2. Okay, so we have a respiratory problem and there's already alkalosis, so respiratory alkalosis. PO2 is normal. The normal PO2 is from 71 to 100, so it's normal. Autostat is normal, and HCO3 is normal as well. Okay, because I forgot to add it. But the normal range is 22 to 36 to 26, so it's within normal range. Okay, so there's no HCO3 abnormalities over here. So the answer would be respiratory alkalosis, and because there is no changes in HCO3, it's decompensated. So, now, what is the mechanism of action of ranolazine? Ranolazine, as we know, it works on the sodium calcium exchanger. Okay. And why does it do that? It does that because ranolazine is a drug that's used in angina. Okay, so when the calcium is lowered from the myocardial tissue, this essentially relaxes the heart and leads to relief. Okay, so it prevents calcium overload by working on the sodium calcium exchanger found in myocardial tissues. Okay, now, which of the following drugs acts on inhibiting the following types of receptors? You have verapamil, dobutamine, furosemide, and digoxin. The answer is digoxin, D. What does digoxin do? It increases intracellular sodium, which reduces the activity of sodium-calcium exchange and increases intracellular calcium. Okay, this increasing of intracellular calcium would enhance myocardial activity. Essentially, it has a positive ionotropic activity, which increases the force of contraction. And that's it. Okay, this is what digoxin does. What drug is associated with the condition of this man? Amiodarone. Next question, we have which phase of the condition of action potential does ivermectin, class 0 antiarrhythmic, act on as indicated by the red arrow? Okay, so we know that ivermectin acts on funny sodium channels. And where are these funny sodium channels? They're usually found in the SA node, okay? So which one of them is an SA node graph? E and D, okay? So we have that figured out. Now, as I said, it acts on funny channels, the sodium funny channels. So this means that it's acting on this part, exactly. So it's acting on phase 4. So the answer is D. Okay? Now, a simple mnemonic to memorize this, specifically this question, ivermectin, is the fact that ivermectin is the first two letters is IV, and it acts on phase 4. IV in numeral numbers means 4. So SA node, phase 4. Just a quick way to keep it in your head. Last question. What is the mechanism of action of verapamil? It's D. Okay? Because verapamil is a calcium channel blocker and it acts on L-type calcium channels. Okay? Now, as you saw, a lot of the questions were pharma-related questions. So please, please, please make sure you memorize the mechanism of action, especially the ones mentioned in these type of graphs. Okay? The graphs for all the antiarrhythmic drugs and these kind of stuff. Okay, so just don't ignore them. The ones discussed in this OSPE were a lot of the most common ones. However, keep memorizing them because there's a chance they might get new questions. That's it for us for this PAL session. Thank you guys so much for watching, and we hope you have benefited even a little bit from any information that we presented here today. Here's the QR code. Please give us feedback for this session so that we can improve and give you better sessions in the future as well. Yeah, thank you so much, and we hope this was beneficial.